Unit 7 Assessing Health 29 Vital Signs 47730 Health Assessment 513. Introduction. Introduction. The traditional vital signs are body temperature, pulse, respirations, and blood pressure. Many agencies such as the Veterans Administration, American Pain Society, and the Joint Commission have designated pain as a fifth vital sign, to be assessed at the same time as each of the other four. Pain assessment is covered in Chapter 46. Oxygen saturation is also commonly measured at the same time as the traditional vital signs. Vital signs, which should be looked at in total, are checked to monitor the functions of the body. The signs reflect changes in function that otherwise might not be observed. Monitoring a client's vital signs should not be an automatic or routine procedure, it should be a thoughtful, scientific assessment. Vital signs should be evaluated with reference to client's present and prior health status, their usual vital sign results, if known, and accepted normal standards. When and how often to assess a specific client's vital signs are chiefly nursing judgments, depending on the client's health status. Some agencies have policies about when to take clients' vital signs. The primary care provider may specifically order a vital sign, example, blood pressure Q2H. Ordered vital sign measurements, however, should be considered the minimum. A nurse should assess vital signs more often if the client's health status requires it. Examples of times to assess vital signs are listed in box 29-1. Often, someone other than the nurse measures the client's vital signs. The nurse must recall, however, that prior to delegating this task to unlicensed assistive personnel, UAP, the nurse must have assessed the individual client and determined that the client is medically stable or in a chronic condition, and not fragile, and that the vital sign measurement is considered routine for this client. Under those circumstances, the UAP may measure, record, and report vital signs. Learning outcomes. After completing this chapter, you will be able to 1. Describe factors that affect the vital signs and accurate measurement of them. 2. Identify the variations in normal body temperature, pulse, respirations, and blood pressure that occur from infancy to old age. 3. Verbalize the steps used in A. Assessing body temperature. B. Assessing a peripheral pulse. C. Assessing the apical pulse and the apical radial pulse. D. Assessing respirations. E. Assessing blood pressure. F. Assessing blood oxygenation using pulse oximetry. Key terms. Afebrile, 479 apical pulse, 487 apical radial pulse, 494 apnea, 497 arrhythmia, 489 arterial blood pressure, 499 arteriosclerosis, 500 auscultatory gap, 503 basal metabolic rate, BMR, 478 body temperature, 478 bradycardia, 489 bradypnea, 497 cardiac output, 487 compliance, 487 conduction, 478 constant fever, 479 convection, 478 core temperature, 478 costal, thoracic, breathing, 496 diaphragmatic, abdominal, breathing, 496 diastolic pressure, 499 dysrhythmia, 489 evaporation, 478 exhalation, 496 expiration, 496 febrile, 479 fever, 479 fever spike, 479 heat balance, 478 heat exhaustion, 479 heat stroke, 480 hematocrit, 500 hyperpyrexia, 479 hypertension, 500 hyperthermia, 479 hyperventilation, 497 hypotension, 501 hypothermia, 480 hypoventilation, 497 inhalation, 496 insensible heat loss, 478 insensible water loss, 478 inspiration, 496 intermittent fever, 479 Kortkoff sounds, 503 mean arterial pressure, MAP, 499 orthostatic hypotension, 501 oxygen saturation, SAW2, 507 peripheral pulse, 487 point of maximal impulse, PMI, 487 pulse, 487 pulse deficit, 494 pulse oximeter, 507 pulse pressure, 499 pulse rhythm, 489 pulse volume, 489 pyrexia, 479 radiation, 478 relapsing fever, 479 remittent fever, 479 respiration, 496 respiratory character, 497 respiratory quality, 497 respiratory rhythm, 497 sphygmomanometer, 501 surface temperature, 478 systolic pressure, 499 tachycardia, 489 tachypnea, 497 tidal volume, 497 ventilation, 496 vital signs, 477 29 vital signs. 4. Describe appropriate nursing care for alterations in vital signs. 5. Identify 9 sites used to assess the pulse, and state the reasons for their use. 6. List the characteristics that should be included when assess ING pulses. 7. Describe the mechanics of breathing, and the mechanisms that control respirations. 8. Recognize when it is appropriate to delegate measurement of vital signs to unlicensed assistive personnel. 9. Demonstrate appropriate documentation and reporting of vital signs. M29B_BERM 4362_10_SE_CH29.IND 477 February 12, 14, 5:51 p.m. 478 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG Number 478 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services Number 153613 CUST, Pearson, Berman PG Number 478 Title, Cozier and Herbs Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services. 2. Muscle activity. Muscle activity, including shivering, increases the metabolic rate. 3. Thyroxine output. Increased thyroxine output increases the rate of cellular metabolism throughout the body. 4. Epinephrine, norepinephrine, and sympathetic stimulation/stress response. These hormones immediately increase the rate of cellular metabolism in many body tissues. 5. Fever. Fever increases the cellular metabolic rate, and thus increases the body's temperature further. Heat is lost from the body through radiation, conduction, convection, and evaporation. Radiation is the transfer of heat from the surface of one object to the surface of another without contact between the two objects, mostly in the form of infrared rays. Conduction is the transfer of heat from one molecule to a molecule of lower temperature. Conductive transfer cannot take place without contact between the molecules and normally accounts for minimal heat loss except, for example, when a body is immersed in cold water. The amount of heat transferred depends on the temperature difference and the amount and duration of the contact. Convection is the dispersion of heat by air currents. The body usually has a small amount of warm air adjacent to it. This warm air rises and is replaced by cooler air, so people always lose a small amount of heat through convection. Evaporation is continuous vaporization of moisture from the respiratory tract and from the mucosa of the mouth and from the skin. This continuous and unnoticed water loss is called insensible water loss, and the accompanying heat loss is called insensible heat loss. Insensible heat loss accounts for about 10% of basal heat loss. When the body temperature increases, vaporization accounts for greater heat loss. But real assessment, interpretation of the measurements, rests with the registered nurse. Body temperature. Body temperature reflects the balance between the heat produced and the heat lost from the body, and is measured in heat units called degrees. There are two kinds of body temperature, core temperature and surface temperature. Core temperature is the temperature of the deep tissues of the body, such as the abdominal cavity and pelvic cavity. It remains relatively constant. The normal core body temperature is a range of temperatures, figure 29:1. The surface temperature is the temperature of the skin, the subcutaneous tissue, and fat. It, by contrast, rises and falls in response to the environment. The body continually produces heat as a byproduct of metabolism. When the amount of heat produced by the body equals the amount of heat lost, the person is in heat balance, figure 29:2. A number of factors affect the body's heat production. The most important are these 5. 1. Basal metabolic rate. The basal metabolic rate, BMR, is the rate of energy utilization in the body required to maintain essential activities such as breathing. Metabolic rates decrease with age. In general, the younger the person, the higher the BMR. Box 29:1 times to assess vital signs. On admission to a healthcare agency to obtain baseline data, when a client has a change in health status or reports symptoms such as chest pain, or feeling hot or faint before and after surgery, or an invasive procedure before and or after the administration of a medication that could affect the respiratory or cardiovascular systems. For example, before giving a digitalis preparation before and after any nursing intervention that could affect the vital signs. Example: ambulating a client who has been on bed rest. Fahrenheit centigrade. Usual range of normal. Figure 29:1 estimated ranges of body temperatures in healthy adults. Heat production, heat loss. Basal metabolic rate, exercise/shivering, secretion of thyroxine, epinephrine, and norepinephrine, inhalation/fever. Radiation, conduction, convection, evaporation. Heat loss. ET vaporation equals. Figure 29:2 As long as heat production and heat loss are properly balanced, body temperature remains constant. Factors contributing to heat production and temperature rise are shown on the left. Those contributing to heat loss and temperature fall are shown on the right. M29B_Berm 4362_10_SE_CH29.IND 478 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 479. Number 153613 CUST, Pearson, Berman PG. Number 479 Title, Cozier and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. Of ovulation raises body temperature by about 0.3 degrees Celsius to 0.6 degrees Celsius, 0.5 degrees Fahrenheit to 1.0 degrees Fahrenheit, above basal temperature. 5. Stress. Stimulation of the sympathetic nervous system can increase the production of epinephrine and norepinephrine, thereby increasing metabolic activity and heat production. Nurses should anticipate that a highly stressed or anxious client could have an elevated body temperature for that reason. 6. Environment. Extremes in environmental temperatures can affect a person's temperature regulatory systems. If the temperature is assessed in a very warm room and the body temperature cannot be modified by convection, conduction, or radiation, the temperature will be elevated. Similarly, if the client has been outside in cold weather without suitable clothing, or if a medical condition prevents the client from controlling the temperature in the environment, example, the client has altered mental status or cannot dress self, the body temperature may be low. Alterations in body temperature. The normal range for adults is considered to be between 36 degrees Celsius and 37.5 degrees Celsius, 96.8 degrees Fahrenheit to 99.5 degrees Fahrenheit. There are two primary alterations in body temperature, pyrexia and hypothermia. Pyrexia, a body temperature above the usual range, is called pyrexia. Hyperthermia, or, in lay terms, fever. A very high fever, such as 41 degrees Celsius, 105.8 degrees Fahrenheit, is called hyperpyrexia, figure 29:4. The client who has a fever is referred to as febrile, the one who does not is afebrile. For common types of fevers are intermittent, remittent, relapsing, and constant. During an intermittent fever, the body temperature alternates at regular intervals between periods of fever and periods of normal or subnormal temperatures. An example is with the disease malaria. During a remittent fever, such as with a cold or influenza, a wide range of temperature fluctuations, more than 2 degrees Celsius, 3.6 degrees Fahrenheit, occurs over a 24-hour period, all of which are above normal. In a relapsing fever, short febrile periods of a few days are interspersed with periods of 1 or 2 days of normal temperature. During a constant fever, the body temperature fluctuates minimally, but always remains above normal. This can occur with typhoid fever, a temperature that rises to fever level rapidly following a normal temperature, and then returns to normal within a few hours is called a fever spike. Bacterial blood infections often cause fever spikes. In some conditions, an elevated temperature is not a true fever. Two examples are heat exhaustion and heat stroke. Heat exhaustion is a result of excessive heat and dehydration. Signs of heat exhaustion include paleness, dizziness, nausea, vomiting, fainting, and a moderately increased temperature, 38.3 degrees Celsius to 38.9 degrees Celsius, 101 degrees Fahrenheit to 102 degrees Fahrenheit. Regulation of body temperature. The system that regulates body temperature has three main parts: sensors in the periphery and in the core, an integrator in the hypothalamus, and an effector system that adjusts the production and loss of heat. Most sensors or sensory receptors are in the skin. The skin has more receptors for cold than warmth. Therefore, skin sensors detect cold more efficiently than warmth. When the skin becomes chilled over the entire body, three physiological processes to increase the body temperature take place. 1. Shivering increases heat production. 2. Sweating is inhibited to decrease heat loss. 3. Vasoconstriction decreases heat loss. The hypothalamic integrator is the center that controls the core temperature. When the integrator detects heat, it sends out signals intended to reduce the temperature, that is, to decrease heat production and increase heat loss. In contrast, when the cold sensors are stimulated, the integrator sends out signals to increase heat production and decrease heat loss. The signals from the cold-sensitive receptors of the hypothalamus initiate effectors, such as vasoconstriction, shivering, and the release of epinephrine, which increases cellular metabolism and hence heat production. When the warmth-sensitive receptors in the hypothalamus are stimulated, the effector system sends out signals that initiate sweating and peripheral vasodilation. Also, when this system is stimulated, the person consciously makes appropriate adjustments, such as putting on additional clothing in response to cold or turning on a fan in response to heat. Factors affecting body temperature. Nurses should be aware of the factors that can affect a client's body temperature so that they can recognize normal temperature variations and understand the significance of body temperature measurements that deviate from normal. Among the factors that affect body temperature are the following. 1. Age. Infants are greatly influenced by the temperature of the environment and must be protected from extreme changes. Children's temperatures vary more than those of adults do until puberty. Many older people, particularly those over 75 years, are at risk of hypothermia, temperatures below 36 degrees Celsius or 96.8 degrees Fahrenheit, for a variety of reasons, such as inadequate diet, loss of subcutaneous fat, lack of activity, and reduced thermoregulatory efficiency. Older adults are also particularly sensitive to extremes in the environmental temperature due to decreased thermoregulatory controls. 2. Diurnal variations, circadian rhythms. Body temperatures normally change throughout the day, varying as much as 1.0 degrees Celsius, 1.8 degrees Fahrenheit, between the early morning and the late afternoon. The point of highest body temperature is usually reached between 1600 and 1800 hours, 4 p.m., and 6 p.m., and the lowest point is reached during sleep between 0400 and 0600 hours, 4 a.m. and 6 a.m., figure 29-3. Older adults' temperatures may vary less than those of younger persons due to the changes in autonomic functioning common in aging. Marigold, Arias, Vassallo, Allen, and Kwan, 2011. 3. Exercise. Hard work or strenuous exercise can increase body temperature to as high as 38.3 degrees Celsius to 40 degrees Celsius, 101 degrees Fahrenheit to 104 degrees Fahrenheit, may assured rectally. 4. Hormones. Women usually experience more hormone fluctuations than men. In women, progesterone secretion at the time 37.2, 37.0, 36.8, 36.6, 36.4, 36.2. 04004 AM 08008 AM 1212 noon 1604 PM 2008 PM 2412 midnight 04004 AM. Awake asleep. Time, hours. Oral temperature, degree C. Figure 29-3 range of oral temperatures during 24 hours for a healthy young adult. M29B_Berm 4362_10_SE_CH29.IND 479 February 12, 14, 5:51 p.m. 480 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG Number 480 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. A lower value, perhaps even back to the original normal level. In this instance, the hypothalamus now attempts to lower the temperature, and the usual heat loss responses that cause a reduction of the body temperature occur: excessive sweating and hot, flushed skin due to sudden vasodilation. This is referred to as the flush phase. Nursing interventions for a client who has a fever are designed to support the body's normal physiological processes, provide comfort, and prevent complications. During the course of a fever, the nurse needs to monitor the client's vital signs closely. Nursing interventions during the chill phase are designed to help the client decrease heat loss. At this time, the body's physiological processes are attempting to raise the core temperature to the new set point temperature. During the flush or crisis phase, the body processes are attempting to lower the core temperature to the reduced or normal set point temperature. At this time, the nurse takes measures to increase heat loss and decrease heat production. Nursing interventions for a client with fever are shown in box 29-2. Hypothermia. Hypothermia is a core body temperature below the lower limit of normal. The three physiological mechanisms of hypothermia are: A. Excessive heat loss, B. Inadequate heat production to counteract heat loss, and C. Impaired hypothalamic thermoregulation. The clinical signs of hypothermia are listed in the clinical manifestations box. Hypothermia may be induced or accidental. Induced hypothermia is the deliberate lowering of the body temperature to decrease the need for oxygen by the body tissues, such as during certain surgeries. Accidental hypothermia can occur as a result of: A. Exposure to a cold environment, B. Immersion in cold water, and C. Lack of adequate clothing, shelter, or heat. In older adults, the problem can be compounded by a decreased metabolic rate and the use of sedative medications. If skin and underlying tissues are damaged by freezing cold. Persons experiencing heat stroke generally have been exercising in hot weather, have warm, flushed skin, and often do not sweat. They usually have a temperature of 41.1 degrees Celsius 106 degrees Fahrenheit or higher, and may be delirious, unconscious, or having seizures. The clinical signs of fever vary with the onset, course, and abatement stages of the fever. See clinical manifestations. These signs occur as a result of changes in the set point of the temperature control mechanism regulated by the hypothalamus. Under normal conditions, whenever the core temperature rises, the rate of heat loss is increased, resulting in a fall in temperature toward the set point level. Conversely, when the core temperature falls, the rate of heat production is increased, resulting in a rise in temperature toward the set point. In a fever, however, the set point of the hypothalamic thermostat changes suddenly from the normal level to a higher than normal value. Example, 39.5 degrees Celsius, 103.1 degrees Fahrenheit, as a result of the effects of tissue destruction. Pyrogenic substances, or dehydration on the hypothalamus. Although the set point changes rapidly, the core body temperature, i.e., the blood temperature, reaches this new set point only after several hours. During this interval, the usual heat production responses that cause elevation of the body temperature occur: chills, feeling of coldness, cold skin due to vasoconstriction, and shivering. This is referred to as the chill phase. When the core temperature reaches the new set point, the person feels neither cold nor hot, and no longer experiences chills, the plateau phase. Depending on the degree of temperature elevation, other signs may occur during the course of the fever. Very high temperatures, such as 41 degrees Celsius to 42 degrees Celsius, 106 degrees Fahrenheit to 108 degrees Fahrenheit, damage the parenchyma of cells throughout the body, particularly in the brain where destruction of neuronal cells is irreversible. Damage to the liver, kidneys, and other body organs can also be great enough to disrupt functioning and eventually cause death. When the cause of the high temperature is suddenly removed, the set point of the hypothalamic thermostat is suddenly reduced to degree F degree C, 42, 41, 40, 39, 38, 37, 36, 35, 34, 107.6, 105.8, 104.0, 102.2, 100.4, 98.6, 96.8, 95.0, 93.2. Normal range. Death. Average. Pyrexia. Hyperpyrexia. Hypothermia. Figure 29 to 4 terms used to describe alterations in body temperature, oral measurements, and ranges in Fahrenheit and Celsius, centigrade, scales. Clinical manifestations. Fever onset, cold or chill phase, increased heart rate, increased respiratory rate, and depth, shivering, pallid, cold skin, complaints of feeling cold, cyanotic nail beds, gooseflesh, appearance of the skin, cessation of sweating. Course, plateau phase, absence of chills, skin that feels warm, photosensitivity, glassy-eyed appearance, increased pulse and respiratory rates, increased thirst, mild to severe dehydration, drowsiness, restlessness, delirium, or convulsions, herpetic lesions of the mouth, loss of appetite, if the fever is prolonged, malaise, weakness, and aching muscles. Defervescence, fever abatement / flush phase, skin that appears flushed and feels warm, sweating, decreased shivering, possible dehydration. M29B_Berm 4362_10_SE_CH29.IND 480 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 481. Number 153613 CUST, Pearson O. Berman PG Number 481 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. With severe hypothermia, a hyperthermia blanket, an electronically controlled blanket that provides a specified temperature, is applied, and warm intravenous fluids are given. Wet clothing, which increases heat loss because of the high conductivity of water, should be replaced with dry clothing. See Box 29-3 for nursing interventions for clients who have hypothermia. Assessing body temperature. The most common sites for measuring body temperature are oral, rectal, axillary, tympanic membrane, and skin/temporal artery. Each of the sites has advantages and disadvantages, Table 29:1. The body temperature may be measured orally. If a client has been taking cold or hot food or fluids or smoking, the nurse should wait 30 minutes before taking the temperature orally to ensure that the temperature of the mouth is not affected by the temperature of the food, fluid, or warm smoke. Rectal temperature readings are considered to be very accurate. Rectal temperatures are contraindicated for clients who undergo rectal surgery, have diarrhea, or diseases of the rectum, are immunosuppressed, have a clotting disorder, or have significant hemorrhoids. The axilla is often the preferred site for measuring temperature in newborns because it is accessible and safe. Axillary temperatures are lower than rectal temperatures. Some clinicians recommend checking an elevated axillary temperature with one taken from an other site to confirm the degree of elevation. Nurses should check agency protocol when taking the temperature of newborns, infants, toddlers, and children. Adult clients for whom the axillary method of temperature assessment is appropriate include those for whom other temperature sites are contraindicated. Nursing interventions for clients with fever. Box 29-2. Monitor vital signs. Assess skin color and temperature. Monitor white blood cell count, hematocrit value, and other pertinent laboratory reports for indications of infection or dehydration. Remove excess blankets when the client feels warm, but provide extra warmth when the client feels chilled. Provide adequate nutrition and fluids, example, 2,500 to 3,000 ml/day, to meet the increased metabolic demands and prevent dehydration. Measure intake and output. Reduce physical activity to limit heat production, especially during the flush stage. Administer antipyretics, drugs that reduce the level of fever, as ordered. Provide oral hygiene to keep the mucous membranes moist. Provide a tepid sponge bath to increase heat loss through conduction. Provide dry clothing and bed linens. Clinical manifestations. Hypothermia. Decreased body temperature, pulse, and respiration, severe shivering, initially, feelings of cold and chills, pale, cool, waxy skin, frostbite, discolored, blistered nose, fingers, toes, hypotension, decreased urinary output, lack of muscle coordination, disorientation, drowsiness, progressing to coma. Nursing interventions for clients with hypothermia. Box 29-3. Provide a warm environment. Provide dry clothing. Apply warm blankets. Keep limbs close to body. Cover the client's scalp with a cap or turban. Supply warm oral or intravenous fluids. Apply warming pads. This results in frostbite. Frostbite most commonly occurs in hands, feet, nose, and ears. Managing hypothermia involves removing the client from the cold and rewarming the client's body. For the client with mild hypothermia, the body is rewarmed by applying blankets for the client. Side advantages, disadvantages: oral accessible and convenient thermometers can break if bitten. Inaccurate if client has just ingested hot or cold food or fluid or smoked. Could injure the mouth following oral surgery. Rectal reliable measurement inconvenient and more unpleasant for clients, difficult for client who cannot turn to the side. Could injure the rectum. Presence of stool may interfere with thermometer placement. Axillary safe and non-invasive. The thermometer may need to be left in place a long time to obtain an accurate measurement. Tympanic membrane readily accessible, reflects the core temperature, very fast, can be uncomfortable, and involves risk of injuring the membrane if the probe is inserted too far. Repeated measurements may vary. Right and left measurements can differ. Presence of cerumen can affect the reading. Temporal artery safe and non-invasive. Very fast, requires electronic equipment that may be expensive or unavailable. Variation in technique needed if the client has perspiration on the forehead. Table 29-1. Advantages and disadvantages of sites used for body temperature measurements. M29B_Berm 4360_10_SE_CH29.IND 481 February 12, 14, 5:51 p.m. 482 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 482 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. The tympanic membrane, or nearby tissue in the ear canal, is a frequent site for estimating core body temperature. However, tympanic temperature measurements have been shown to be imprecise. Rubia, Arias, Sierra, and Aguirre Jamie, 2011. If the probe fits too loosely in the ear canal, the reading can be lower than the true value. Electronic tympanic thermometers are found extensively in both inpatient and ambulatory care settings. The temperature may also be measured on the forehead using a chemical thermometer or a temporal artery thermometer. Forehead temperature measurements are most useful for infants and children when a more invasive measurement is not necessary. However, temporal artery temperature measurements have shown inconsistent reliability. Penning, van der Linden, Tibble, and Evenhuis, 2011. Rubia et al., 2011. Types of thermometers. Traditionally, body temperatures were measured using mercury in glass thermometers. Such thermometers, however, can be hazardous due to exposure to mercury, which is toxic to humans, and broken glass should the thermometer crack or break. In 1998, the U.S. Environmental Protection Agency and the American Hospital Association agreed to the goal of eliminating mercury from healthcare environments. Hospitals no longer use mercury in glass thermometers, and several cities have banned the sale and manufacture of them. However, the nurse may still encounter this type of thermometer, especially in the home. In some cases, plastics have replaced glass and safer chemicals, example, gallium, have replaced mercury in modern versions of the thermometer. Although the amount of mercury in a thermometer, or in a fluorescent light bulb, is minimal, should it break, cleanup involves several do's and don'ts. Unsealed mercury slowly vaporizes into the air, and these mercury vapors are toxic. Keep children and pets away from the area. Wearing rubber gloves, wipe mercury beads off cloth skin, or disposable items with a paper towel, and immediately place the towel into a plastic bag. Discard the bag. If the spill is on a porous material that cannot be discarded, example, carpet, a contractor trained in mercury disposal may be needed. If the mercury is on a hard surface, use folded stiff cardboard to slowly gather the beads and pour them into a wide-mouthed container. Use a flashlight to search for the beads since the light will reflect off the mercury. Dispose of all items used in the cleanup in a plastic bag that is sealed with tape. Shower or wash well. Keep the area well ventilated for several days. Do not use any type of vacuum cleaner or broom since these will disperse the mercury and be contaminated. Do not pour the mercury down a toilet or drain, and do not wash or reuse contaminated materials. Figure 29-5 Electronic thermometers. A. Institutional model. Note the probe and probe cover. B. One-piece home electronic thermometer. A. B. With ovulation. Hypothermia thermometers have a greater low range than everyday thermometers, usually measuring temperatures from 27.2 degrees Celsius to 42.2 degrees Celsius, 81 degrees Fahrenheit to 108 degrees Fahrenheit. Chemical disposable thermometers are also used to measure body temperatures. Chemical thermometers have liquid crystal dots or bars that change color to indicate temperature. Some of these are single-use and others may be reused several times. One type that has small chemical dots at one end is shown in figure 29-6. To read the temperature, the nurse notes the highest reading among the dots that have changed color. These thermometers can be used orally, rectally, or in the axilla. Temperature-sensitive tape may also be used to obtain a general indication of body surface temperature. It does not indicate the core temperature. The tape contains liquid crystals that change color according to temperature. When applied to the skin, usually of the forehead or abdomen, the temperature digits on the tape respond by changing color. Figure 29 to 7. The skin area should be dry. After the length of time specified by the manufacturer, example, 15 seconds, a color appears on the tape. This method is particularly useful at home and for infants whose temperatures are to be monitored. Electronic thermometers can provide a reading in only 2 to 60 seconds, depending on the model. The equipment consists of an electronic base, a probe, and a probe cover, which is usually disposable, figure 29 to 5. Some institutional models have a different circuit and probe for oral and rectal measurement. Two special types of oral thermometers are basal and hypothermia. A basal thermometer is calibrated with 0.1 degrees Fahrenheit intervals and is for fertility purposes, indicating the temperature rise that is associated. Safety alert. Whenever mercury in glass thermometers are encountered, the nurse should recommend their immediate replacement with less hazardous thermometers and their safe disposal. Safety. M29B_BERM 4362_10_SE_CH29.IND482 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 483. Number 153613 CUST, Pearson, Berman PG Number 483 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. For example, when the Celsius reading is 40. F equals 43 and 9/5, 132 equals 72 132 equals 104. Skill 29 to 1 explains how to measure body temperature. Infrared thermometers sense body heat in the form of infrared energy given off by a heat source, which, in the ear canal, is primarily the tympanic membrane, figure 29 to 8. The infrared thermometer makes no contact with the tympanic membrane. Temporal artery thermometers determine temperature using a scanning infrared thermometer that compares the arterial temperature in the temporal artery of the forehead to the temperature in the room, and calculates the heat balance to approximate the core temperature of the blood in the pulmonary artery. The probe is placed in the middle of the forehead, and then drawn laterally to the hairline. If the client has perspiration on the forehead, the probe is also touched behind the earlobe so the thermometer can compensate for evaporative cooling, figure 29 to 9. Temperature scales. Sometimes a nurse needs to convert a body temperature reading in Celsius, centigrade, to Fahrenheit, or vice versa. Although the conversion can be accomplished using several different formulas, the most common is described here. To convert from Fahrenheit to Celsius, deduct 32 from the Fahrenheit reading, and then multiply by the fraction 5/9, that is. C equals Fahrenheit temperature 232, 3 and 5/9. For example, when the Fahrenheit reading is 100. C equals 100232, 3 and 5/9 equals 68, 3 and 5/9 equals 37.8. To convert from Celsius to Fahrenheit, multiply the Celsius reading by the fraction 9/5, and then add 32, that is. F equals Celsius temperature 3 and 9/5, 132. Figure 29 to 7 a temperature-sensitive skin tape. Figure 29 to 8 an infrared, tympanic, thermometer used to measure the tympanic membrane temperature. Figure 29 to 9 a temporal artery thermometer. Copyright A. Wilson/Custom Medical Stock Photo. 100 101 102 103 104. 96 97 98 99. Degree F.0.2.4.6.8. Ax. 100 101 102 103 104. 100 101 102 103 104. 100 101 102 103 104. 96 97 98 99 degree F.0.2.4.6.8. 96, 97, 98, 99. Degree F. 0.2.4.6.8. A. B. C. D. Figure 29 to 6 chemical dot thermometers. A. Axillary. Note the ax on the stem. B. Rectal. Note the plastic cover. C. Oral. D. An enlargement showing a reading of 99.2 degrees Fahrenheit. M29B _ berm 4362_10_SE_CH29.IND 483 February 12, 14, 5:51 p.m. 484 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 484 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Purposes to establish baseline data for subsequent evaluation to identify whether the core temperature is within normal range to determine changes in the core temperature in response to specific therapies, example, antipyretic medication, immunosuppressive therapy, invasive procedure. Equipment thermometer sheath, or cover water-soluble lubricant for a rectal temperature. Assessment assess clinical signs of fever, clinical signs of hypothermia. Planning delegation. Routine measurement of the client's temperature can be delegated to unlicensed assistive personnel, UAP, or be performed by family members/caregivers in non-hospital settings. The nurse must explain the appropriate type of thermometer and site to be used and ensure that the person knows when to report an abnormal temperature and how to record the finding. The interpretation of an abnormal temperature and determination of appropriate responses are done by the nurse. Implementation preparation check that all equipment is functioning normally. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. Apply gloves if performing a rectal temperature. 3. Provide for client privacy. 4. Position the client appropriately, example, lateral or Sims position for inserting a rectal thermometer. 5. Place the thermometer, box 29-4. Apply a protective sheath or probe cover if appropriate. Lubricate a rectal thermometer. 6. Wait the appropriate amount of time. Electronic and tympanic thermometers will indicate that the reading is complete through a light or tone. Check package instructions for length of time to wait prior to reading chemical dot or tape thermometers. Evaluation. Compare the temperature measurement to baseline data, normal range for age of client, and client's previous temperatures. Analyze considering time of day and any additional influencing factors and other vital signs. Conduct appropriate follow-up such as notifying the primary care provider if a temperature is outside of a specific range or is not responding to interventions, giving a medication, or interprofessional practice. Measuring the temperature may be within the scope of practice for many healthcare providers. Although these other providers may verbally communicate their findings and plan to the healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. 7. Remove the thermometer and discard the cover or wipe with a tissue if necessary. If gloves were applied, remove and discard them. Perform hand hygiene. 8. Read the temperature and record it on your worksheet. If the temperature is obviously too high, too low, or inconsistent with the client's condition, recheck it with a thermometer known to be functioning properly. 9. Wash the thermometer if necessary and return it to the storage location. 10. Document the temperature in the client record. A rectal temperature may be recorded with an R next to the value, or with the mark on a graphic sheet circled. An axillary temperature may be recorded with AX or marked on a graphic sheet with an X. Altering the client's environment. This includes teaching the client how to lower an elevated temperature through actions such as increasing fluid intake, coughing and deep breathing, cool compresses, or removing heavy coverings. Interventions for hypothermia include intake of warm fluids and use of warm or electric blankets. Clinical alert. Be sure to record the temperature from an electronic thermometer before replacing the probe into the charging unit. With many models, replacing the probe erases the temperature from the display. To monitor clients at risk for imbalanced body temperature, example, clients at risk for infection or diagnosis of infection, those who have been exposed to temperature extremes. Site and method most appropriate for measurement factors that may alter core body temperature. Clean gloves for a rectal temperature towel for axillary temperature tissues/wipes. Assessing body temperature. Skill 29-1. M29B_Berm 4362_10_SE_CH29.IND484 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 485. Number 153613 CUST, Pearson, Berman PG number 485 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Vital Signs Record. Vital Signs Record from Cerner Electronic Health Record. Copyright by Cerner Corporation. Used by permission of Cerner Corporation. Assessing body temperature, continued. Skill 29-1. Box 29-4 Thermometer placement. Oral place the tip on either side of the frenulum. Rectal apply clean gloves. Instruct the client to take a slow deep breath during insertion. Never force the thermometer if resistance is felt. Insert 3.5 centimeters 1.5 inches in adults. Axillary pat the axilla dry if very moist. The tip is placed in the center of the axilla. Oral thermometer placement. Positioning a temporal artery thermometer. Copyright Exergen Corporation. All rights reserved. Pull the pinna of the ear up and back for an adult while inserting the tympanic thermometer. Placing the tip of the thermometer in the center of the axilla. Inserting a rectal thermometer. Tympanic pull the pinna slightly upward and backward for an adult. Point the probe slightly anteriorly, toward the eardrum. Insert the probe slowly using a circular motion until snug. Temporal artery brush hair aside if covering the temporal artery area. With the probe flush on the center of the forehead, depress the red button, keep depressed. Slowly slide the probe midline across the forehead to the hairline, not down the side of the face. Lift the probe from the forehead and touch on the neck just behind the earlobe. Release the button. M29B_Berm 4362_10_SE_CH29.IND485 February 12, 14, 5:51 p.m. 486 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG number 486 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Lifespan Considerations. Temperature. Infants. The body temperature of newborns is extremely labile, and newborns must be kept warm and dry to prevent hypothermia. Using the axillary site, you need to hold the infant's arm against the chest, figure 29-10. The axillary route may not be as accurate as other routes for detecting fevers in children. The tympanic route is fast and convenient. Place the infant supine and stabilize the head. Pull the pinna straight back and slightly downward. Remember that the pinna is pulled upward for children over 3 years of age and adults, but downward for children younger than age 3. Direct the probe tip anteriorly and insert far enough to seal the canal. The tip will not touch the tympanic membrane. Avoid the tympanic route in a child with active ear infections or tympanic membrane drainage tubes. The tympanic membrane route may be more accurate in determining temperature in febrile infants. When using a temporal artery thermometer, touching only the forehead or behind the ear is needed. The rectal route is least desirable in infants. Children tympanic or temporal artery sites are preferred. For the tympanic route, have the child held on an adult's lap with the child's head held gently against the adult for support. Pull the pinna straight back and upward for children over age 3, figure 29 to 11. Avoid the tympanic route in a child with active ear infections or tympanic membrane drainage tubes. The oral route may be used for children over age 3, but non-breakable, electronic thermometers are recommended. For a rectal temperature, place the child prone across your lap or in a side-lying position with the knees flexed. Insert the thermometer 2.5 centimeters 1 inch into the rectum. Older adults' temperatures tend to be lower than those of middle-aged adults. Older adults' temperatures are strongly influenced by both environmental and internal temperature changes. Their thermoregulation control processes are not as efficient as when they were younger, and they are at higher risk for both hypothermia and hyperthermia. Older adults can develop significant buildup of ear cerumen, earwax, that may interfere with tympanic thermometer readings. Older adults are more likely to have hemorrhoids. Inspect the anus before taking a rectal temperature. Older adults' temperatures may not be a valid indication of the seriousness of the pathology of a disease. They may have pneumonia or a urinary tract infection and have only a slight temperature elevation. Other symptoms, such as confusion and restlessness, may be displayed and need follow-up to determine if there is an underlying process. Figure 29 to 10 axillary thermometer placement for a child. Figure 29 to 11 pull the pinna of the ear back and up for placement of a tympanic thermometer in a child over 3 years of age, back and down for children under age 3. Figure 29 to 12 a pacifier thermometer. Home care considerations. Temperature. Teach the client accurate use and reading of the type of thermometer to be used. Examine the thermometer used by the client in the home for safety and proper functioning. Facilitate the replacement of mercury thermometers with non-mercury ones. See page 482 for instructions regarding management of a broken mercury thermometer. Observe the client/caregiver taking and reading a temperature. Reinforce the importance of reporting the site and type of thermometer used and the value of using the same site and thermometer consistently. Discuss means of keeping the thermometer clean, such as warm water and soap, and avoiding cross-contamination. Ensure that the client has water-soluble lubricant if using a rectal thermometer. Instruct the client or family member to notify the healthcare provider if the temperature is 38.5 degrees Celsius 101.3 degrees Fahrenheit or higher. When making a home visit, take a thermometer with you in case the clients do not have a functional thermometer of their own. Check that the client knows how to record the temperature. Provide a recording chart/table if indicated. Discuss environmental control modifications that should be made during illness or extreme climate conditions, example, heating, air conditioning, appropriate clothing and bedding. Pacifier thermometers, figure 29 to 12, may be used in the home setting for children under 2 years old. The manufacturer's instructions must be followed carefully since many require adding 0.5 degrees Fahrenheit in order to estimate rectal temperature. Patient-centered care. M29B_Berm 4362_10_SE_CH29.IND486 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 487. Number 153613 CUST, Pearson, Berman PG Number 487 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Preparations, decrease the heart rate, whereas epinephrine increases it. Hypovolemia/dehydration. Loss of blood from the vascular system increases the pulse rate. In adults, the loss of circulating volume results in an adjustment of the heart rate to increase blood pressure as the body compensates for the lost blood volume. Stress. In response to stress, sympathetic nervous stimulation increases the overall activity of the heart. Stress increases the rate as well as the force of the heartbeat. Fear and anxiety as well as the perception of severe pain stimulate the sympathetic system. Position. When a person is sitting or standing, blood usually pools in dependent vessels of the venous system. Pooling results in a transient decrease in the venous blood return to the heart, and a subsequent reduction in blood pressure and increase in heart rate. Pathology. Certain diseases such as some heart conditions or those that impair oxygenation can alter the resting pulse rate. Pulse sites. A pulse may be measured in 9 sites, figure 29 to 13. 1. Temporal, where the temporal artery passes over the temporal bone of the head. The site is superior, above, and lateral to, away from the midline of, the eye. Pulse. The pulse is a wave of blood created by contraction of the left ventricle of the heart. Generally, the pulse wave represents the stroke volume output, or the amount of blood that enters the arteries with each ventricular contraction. Compliance of the arteries is their ability to contract and expand. When a person's arteries lose their distensible ITY, as can happen with age, greater pressure is required to pump the blood into the arteries. Cardiac output is the volume of blood pumped into the arteries by the heart, and equals the result of the stroke volume, SV, times the heart rate, HR, per minute. For example, 65 ml 370 beats per minute 4.55 L per minute. When an adult is resting, the heart pumps about 5 liters of blood each minute. In a healthy person, the pulse reflects the heartbeat. That is, the pulse rate is the same as the rate of the ventricular contractions of the heart. However, in some types of cardiovascular disease, the heartbeat and pulse rates can differ. For example, a client's heart may produce very weak or small pulse waves that are not detectable in a peripheral pulse far from the heart. In these instances, the nurse should assess the heartbeat and the peripheral pulse. A peripheral pulse is a pulse located away from the heart, for example, in the foot or wrist. The apical pulse, in contrast, is a central pulse, that is, it is located at the apex of the heart. It is also referred to as the point of maximal impulse, PMI. Factors affecting the pulse. The rate of the pulse is expressed in beats per minute, beats/min. A pulse rate varies according to a number of factors. The nurse should consider each of the following factors when assessing a client's pulse. Age. As age increases, the pulse rate gradually decreases overall. See Table 29-2 for specific variations in pulse rates from birth to adulthood. Sex. After puberty, the average male's pulse rate is slightly lower than the female's. Exercise. The pulse rate normally increases with activity. The rate of increase in the professional athlete is often less than in the average person because of greater cardiac size, strength, and efficiency. Fever. The pulse rate increases, A, in response to the lowered blood pressure that results from peripheral vasodilation associated with elevated body temperature, and B, because of the increased metabolic rate. Medications. Some medications decrease the pulse rate, and others increase it. For example, carditonics, example, digitalis. Carotid. Apical brachial. Femoral. Temporal. Radial. Popliteal. Dorsalis pedis. Posterior tibial. Figure 29-13 9 sites for assessing pulse. Variations in pulse and respirations by age. Table 29-2. Age, pulse average, and ranges. Respirations average, and ranges. Newborn 130, 80 to 180, 35, 30 to 60. 1 year 120, 80 to 140, 30, 20 to 40, 5 to 8 years 100, 75 to 120, 20, 15 to 25, 10 years 70, 50 to 90, 19, 15 to 25, teen 75, 50 to 90, 18, 15 to 20, adult 80, 60 to 100, 16, 12 to 20, older adult 70, 60 to 100, 16, 15 to 20. M29B_Berm 4362_10_SE_CH29.IND 487 February 12, 14, 5:51 p.m. 488 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 488 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services. 2. Carotid, at the side of the neck where the carotid artery runs between the trachea and the sternocleidomastoid muscle. Clinical alert. Never press both carotids at the same time, because this can cause a reflex drop in blood pressure or pulse rate. Apical pulse before age 4. Apical pulse at ages 4 to 6. Apical pulse in adult body of sternum. Anterior axillary angle of line Lewis. Manubrium of sternum clavicle. Midsternal line midclavicular line. Figure 29 to 14 Location of the apical pulse for a child under 4 years, a child 4 to 6 years, and an adult. 3. Apical, at the apex of the heart. In an adult, this is located on the left side of the chest, about 8 centimeters 3 inches to the left of the sternum, breastbone, at the 5th intercostal space, area between the ribs. In older adults, the apex may be further left if conditions are present that have led to an enlarged heart. Before 4 years of age, the apex is left of the midclavicular line, MCL. Between 4 and 6 years, it is at the MCL, figure 29 to 14. For a child 7 to 9 years of age, the apical pulse is located at the 4th or 5th intercostal space. 4. Brachial, at the inner aspect of the biceps muscle of the arm, or medially in the antecubital space. 5. Radial, where the radial artery runs along the radial bone, on the thumb side of the inner aspect of the wrist. 6. Femoral, where the femoral artery passes alongside the inguinal ligament. 7. Popliteal, where the popliteal artery passes behind the knee. 8. Posterior tibial, on the medial surface of the ankle where the pos. Anterior tibial artery passes behind the medial malleolus. 9. Dorsalis pedis, where the dorsalis pedis artery passes over the bones of the foot, on an imaginary line drawn from the middle of the ankle to the space between the big and second toes. The radial site is most commonly used in adults. It is easily found in most people and readily accessible. Some reasons for use of each site are given in Table 29 to 3. Assessing the pulse. A pulse is commonly assessed by palpation, feeling, or auscultation, hearing. The middle 3 fingertips are used for palpating all pulse sites, except the apex of the heart. A stethoscope is used for assessing apical pulses. A Doppler ultrasound stethoscope, DUS, figure 29 to 15, is used for pulses that are difficult to assess. The DUS headset has earpieces similar to standard stethoscope earpieces, but it has a long cord attached to a volume-controlled audio unit and an ultrasound transducer. The DUS detects movement of red blood cells through a blood vessel. In contrast to the conventional stethoscope, it eliminates environmental sounds. A pulse is normally palpated by applying moderate pressure with the 3 middle fingers of the hand. The pads on the most distal aspects of the finger are the most sensitive areas for detecting a pulse. With excessive pressure, one can obliterate a pulse, whereas with too little pressure one may not be able to detect it. Before the nurse assesses the resting pulse, the client should assume a comfortable position. The nurse should also be aware of the following: any medication that could affect the heart rate, whether the client has been physically active, If so, wait 10 to 15 minutes until the client has rested and the pulse has slowed to its usual rate. Figure 29 to 15. A Doppler ultrasound stethoscope, DUS. Pulse site reasons for use. Radial readily accessible temporal used when radial pulse is not accessible. Carotid used during cardiac arrest/shock in adults. Used to determine circulation to the brain. Apical routinely used for infants and children up to 3 years of age. Used to determine discrepancies with radial pulse. Used in conjunction with some medications. Brachial used to measure blood pressure. Used during cardiac arrest for infants. Femoral used in cases of cardiac arrest/shock. Used to determine circulation to a leg. Popliteal, used to determine circulation to the lower leg. Posterior tibial, used to determine circulation to the foot. Dorsalis pedis, used to determine circulation to the foot. Reasons for using specific pulse site. Table 29 to 3. M29B_Berm 4362_10_SE_CH29.IND 488 February 12, 5:51 p.m. Chapter 29 Vital Signs 489. Number 153613 CUST, Pearson, Berman PG. Number 489. Title, Cozier and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. Obliterated with greater pressure. A forceful or full blood volume that is obliterated only with difficulty is called a full or bounding pulse. A pulse that is readily obliterated with pressure from the fingers is referred to as weak, feeble, or thready. The elasticity of the arterial wall reflects its expansibility or its deformities. A healthy, normal artery feels straight, smooth, soft, and pliable. Older adults often have inelastic arteries that feel twisted, tortuous, and irregular on palpation. When assessing a peripheral pulse to determine the adequacy of blood flow to a particular area of the body, perfusion, the nurse should also assess the corresponding pulse on the other side of the body. The second assessment gives the nurse data with which to compare the pulses. For example, when assessing the blood flow to the right foot, the nurse assesses the right dorsalis pedis pulse and then the left dorsalis pedis pulse. If the client's right and left pulses are the same volume and elasticity, the client's dorsalis pedis pulses are bilaterally equal. The pulse rate does not need to be counted when assessing for perfusion and equality. When a peripheral pulse is located, it indicates that pulses more proximal to that location will also be present. For example, if the dorsalis pedis, the most distal pulse of the lower extremity, cannot be felt, the nurse next palpates for the posterior tibial pulse. If it is not felt, the popliteal pulse must be assessed. If the popliteal pulse is found, it is not necessary to assess the femoral pulse, since it must also be present in order for the more distal pulse to exist. Skill 29-2 provides guidelines for assessing a peripheral pulse. Any baseline data about the normal heart rate for the client. For example, a physically fit athlete may have a resting heart rate below 60 beats/min. Whether the client should assume a particular position, example, sitting. In some clients, the rate changes with the position because of changes in blood flow volume and autonomic nervous system activity. When assessing the pulse, the nurse collects the following data: the rate, rhythm, volume, arterial wall elasticity, and presence or absence of bilateral equality. An excessively fast heart rate, example, over 100 beats/min in an adult, is referred to as tachycardia. A heart rate in an adult of less than 60 beats/min is called bradycardia. If a client has either tachycardia or bradycardia, the apical pulse should be assessed. The pulse rhythm is the pattern of the beats and the intervals between the beats. Equal time elapses between beats of a normal pulse. A pulse with an irregular rhythm is referred to as a dysrhythmia or arrhythmia. It may consist of random, irregular beats, or a predictable pattern of irregular beats, documented as regularly irregular. When a dysrhythmia is detected, the apical pulse should be assessed. An electrocardiogram, ECG, is necessary to define the dysrhythmia further. Pulse volume, also called the pulse strength or amplitude, Re. FERS to the force of blood with each beat. Usually, the pulse volume is the same with each beat. It can range from absent to bounding. A normal pulse can be felt with moderate pressure of the fingers and can be purposes to establish baseline data for subsequent evaluation to identify whether the pulse rate is within normal range to determine the pulse volume, and whether the pulse rhythm is regular to determine the equality of corresponding peripheral pulses on each side of the body. Assessment: assess clinical signs of cardiovascular alterations such as dyspnea, difficult respirations, fatigue, pallor, cyanosis, bluish discoloration of skin and mucous membranes, palpitations, syncope, fainting, or impaired peripheral tissue perfusion, as evidenced by skin discoloration and cool temperature. Planning delegation. Measurement of the client's radial or brachial pulse can be delegated to UAP, or be performed by family members/caregivers in non-hospital settings. Reports of abnormal pulse rates or rhythms require reassessment by the nurse, who also determines appropriate action if the abnormality is confirmed. UAP are generally not delegated these techniques due to the skill required in locating and interpreting peripheral pulses other than the radial or brachial artery, and in using Doppler ultrasound devices. Equipment: clock or watch with a sweep second hand or digital seconds indicator. To monitor and assess changes in the client's health status. To monitor clients at risk for pulse alterations, example, those with a history of heart disease or experiencing cardiac arrhythmias, hemorrhage, acute pain, infusion of large volumes of fluids, or fever, to evaluate blood perfusion to the extremities. Factors that may alter pulse rate, example, emotional status and activity level, which site is most appropriate for assessment based on the purpose. Interprofessional practice. Assessing a peripheral pulse may be within the scope of practice for many healthcare providers. For example, in addition to nurses, both physical therapists and respiratory therapists may check the client's pulse before, during, and after treatment. Although these therapists may verbally communicate their findings and plan to the healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. If using a DUS, transducer probe, stethoscope headset, some models, transmission gel, and tissues/wipes. Assessing a peripheral pulse. Skill 29-2. Continued on page 490. M29B_Berm 4362_10_SE_CH29.IND 489 February 12, 5:51 p.m. 490 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG Number 490 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Select the pulse point. Normally, the radial pulse is taken, unless it cannot be exposed or circulation to another body area is to be assessed. 5. Assist the client to a comfortable resting position. When the radial pulse is assessed, with the palm facing downward, the client's arm can rest alongside the body, or the forearm can rest at a 90-degree angle across the chest. For the client who can sit, the forearm can rest across the thigh, with the palm of the hand facing downward or inward. 6. Palpate and count the pulse. Place 2 or 3 middle fingertips lightly and squarely over the pulse point. Implementation preparation. If using a DUS, check that the equipment is functioning normally. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. Assessing pulses, a radial B brachial. C carotid. D femoral. Epopliteal F posterior tibial. Assessing a peripheral pulse, continued. Skill 29-2. M29B_Berm 4362_10_SE_CH29.IND 490 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 491. Number 153613 CUST, Pearson O. Berman PG Number 491 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing a peripheral pulse, continued. Skill 29-2. Rationale. Using the thumb is contraindicated because the nurse's thumb has a pulse that could be mistaken for the client's pulse. Count for 15 seconds and multiply by 4. Record the pulse in beats per minute on your worksheet. If taking a client's pulse for the first time, when obtaining baseline data, or if the pulse is irregular, count for a full minute. If an irregular pulse is found, also take the apical pulse. 7. Assess the pulse rhythm and volume. Assess the pulse rhythm by noting the pattern of the intervals between the beats. A normal pulse has equal time periods between beats. If this is an initial assessment, assess for 1 minute. Assess the pulse volume. A normal pulse can be felt with moderate pressure, and the pressure is equal with each beat. A forceful pulse volume is full, an easily obliterated pulse is weak. Record the rhythm and volume on your worksheet. 8. Document the pulse rate, rhythm, and volume and your actions. In the client record, see figure in Skill 29-1. Also record in the nurse's notes pertinent related data, such as variation in pulse rate, compared to normal, for the client, and abnormal skin color and skin temperature. Variation, using a DUS if used. Plug the stethoscope headset into one of the 2 output jacks located next to the volume control. DUS units may have 2 jacks so that a second person can listen to the signals. Apply transmission gel either to the probe at the narrow end of the plastic case housing the transducer, or to the client's skin. Rationale: ultrasound beams do not travel well through air. The gel makes an airtight seal, which then promotes optimal ultrasound wave transmission. Press the on button. Hold the probe against the skin over the pulse site. Use a light pressure, and keep the probe in contact with the skin. Rationale: too much pressure can stop the blood flow and obliterate the signal. Adjust the volume if necessary. Distinguish artery sounds from vein sounds. The artery sound, signal, is distinctively pulsating, and has a pumping quality. The venous sound is intermittent and varies with respirations. Both artery and vein sounds are heard simultaneously through the DUS, because major arteries and veins are situated close together throughout the body. If arterial sounds cannot be easily heard, reposition the probe. If you can not hear any pulse, move the probe to several different locations in the same area before determining that no pulse is present. After assessing the pulse, remove all gel from the probe to prevent damage to the surface. Clean the transducer with water-based solution. Rationale: alcohol or other disinfectants may damage the face of the transducer. Remove all gel from the client. Using a DUS to assess the posterior tibial pulse. Evaluation: compare the pulse rate to baseline data, or normal range for age of client. Relate pulse rate and volume to other vital signs. Relate pulse rhythm and volume to baseline data and health status. If assessing peripheral pulses, evaluate equality, rate, and volume in corresponding extremities. Conduct appropriate follow-up such as notifying the primary care provider or giving medication. G. dorsalis pedis. Apical pulse assessment. Assessment of the apical pulse is indicated for clients whose peripheral pulse is irregular or unavailable, and for clients with known cardiovascular, pulmonary, and renal diseases. It is commonly assessed prior to administering medications that affect heart rate. The apical site is also used to assess the pulse for newborns, infants, and children up to 2 to 3 years old. Skill 29-3 presents guidelines for assessing the apical pulse. M29B_Berm 4362_10_SE_CH29.IND 491 February 12, 14, 5:51 p.m. 492 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG Number 492 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing an apical pulse. Skill 29-3. Purposes to obtain the heart rate of an adult with an irregular peripheral pulse to establish baseline data for subsequent evaluation. To determine whether the cardiac rate is within normal range and the rhythm is regular, to monitor clients with cardiac, pulmonary, or renal disease, and those receiving medications to improve heart action. Assessment. Assess clinical signs of cardiovascular alterations such as dyspnea, difficult respirations, fatigue/weakness, pallor, cyanosis, bluish discoloration of skin and mucous membranes, palpitations, syncope, fainting, or impaired peripheral tissue perfusion as evidenced by skin discoloration and cool temperature. Factors that may alter pulse rate, example, emotional status, activity level, and medications that affect heart rate such as digoxin, beta blockers, or calcium channel blockers. Planning. Delegation. Due to the degree of skill and knowledge required, UAP are generally not responsible for assessing apical pulses. Equipment. Clock or watch with a sweep, second hand or digital seconds indicator, stethoscope, antiseptic wipes if using a DUS, the transducer probe, the stethoscope headset, transmission gel, and tissue/wipes. Interprofessional practice. Assessing an apical pulse may be within the scope of practice for many healthcare providers. For example, in addition to nurses, respiratory therapists may check the client's apical pulse before, during, and after treatment, and physicians often check the apical pulse when assessing the chest during examinations. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Second intercostal space. Shirley Snyder. Implementation preparation. If using a DUS, check that the equipment is functioning normally. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Position the client appropriately in a comfortable supine position, or in a sitting position. Expose the area of the chest over the apex of the heart. 5. Locate the apical impulse. This is the point over the apex of the heart, where the apical pulse can be most clearly heard. Palpate the angle of Lewis, the angle between the monobrium, the top of the sternum, and the body of the sternumber. It is palpated just below the suprasternal notch, and is felt as a prominence, see figure 29-14. Slide your index finger just to the left of the sternum and palpate the second intercostal space. Clinical alert. When left and right are used to describe the nurse's hand placement on the client, the terms refer to the client's right or left side, not the nurse's. Place your middle or next finger in the third intercostal space, and continue palpating downward until you locate the fifth intercostal space. Move your index finger laterally along the fifth intercostal space toward the MCL. Normally, the apical impulse is palpable at or just medial to the MCL, see figure 29-14. 6. Auscultate and count heartbeats. Use antiseptic wipes to clean the earpieces and diaphragm of the stethoscope. Rationale. the diaphragm needs to be cleaned and disinfected if soiled with body substances. Both earpieces and diaphragms have been shown to harbor pathogenic bacteria, Muniz, Sethi, Zaghi, Zinial, and Sandora, 2012. M29B_4362_10_SE_CH29.IND492 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 493. Number 153613 CUST, Pearson, Berman PG Number 493 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Continued on page 494. Assessing an apical pulse, continued. Skill 29-3. Third intercostal space. Shirley Snyder. Warm the diaphragm of the stethoscope by holding it in the palm of the hand for a moment. Rationale: the metal of the diaphragm is usually cold and can startle the client when placed immediately on the chest. Insert the earpieces of the stethoscope into your ears in the direction of the ear canals, or slightly forward. Rationale: this position facilitates hearing. Tap your finger lightly on the diaphragm. Rationale: this is to be sure it is the active side of the head. If necessary, rotate the head to select the diaphragm side. Place the diaphragm of the stethoscope over the apical impulse, and listen for the normal S1 and S2 heart sounds, which are heard as lube-dub. Rationale: the heartbeat is normally loudest over the apex of the heart. Each lube-dub is counted as one heartbeat. Rationale: the two heart sounds are produced by closure of the heart valves. The S1 heart sound, lube, occurs when the atrioventricular valves close after the ventricles have been sufficiently filled. The S2 heart sound, dub, occurs when the semilunar valves close after the ventricles empty. If you have difficulty hearing the apical pulse, ask the supine client to roll onto his or her left side, or the sitting client to lean slightly forward. Rationale: this positioning moves the apex of the heart closer to the chest wall. If the rhythm is regular, count the heartbeats for 30 seconds and multiply by 2. If the rhythm is irregular or for giving certain medications, such as digoxin, count the beats for 60 seconds. Fifth intercostal space, MCL. Shirley Snyder. Taking an apical pulse using the flat disc stethoscope. Note how the amplifier is held against the chest. Rationale: a 60-second count provides a more accurate assessment of an irregular pulse than a 30-second count. 7. Assess the rhythm and the strength of the heartbeat. Assess the rhythm of the heartbeat by noting the pattern of intervals between the beats. A normal pulse has equal time periods between beats. Assess the strength, volume, of the heartbeat. Normally, the heartbeats are equal in strength and can be described as strong or weak. A. Stethoscope with both a bell and a diaphragm. B. Close-up of a bell, left, and a diaphragm, right. A. B. M29B_4362_10_SE_CH29.IND493 February 12, 14, 5:51 p.m. 494 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG Number 494 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing an apical pulse, continued. Skill 29-3. 8. Document the pulse rate and rhythm, and nursing actions in the client record. Also record pertinent related data, such as variation in pulse rate, compared to normal, for the client, and abnormal skin color and skin temperature. Sample documentation. February 24, 16 1000 radial pulse 116 and irregular. Had been 82 and regular at 0600. TR and BP within client's usual range. C/O being a little dizzy. Skin warm and dry. Apical pulse 120, irregular, with brief pause after Q third beat. MD notified and ECG ordered. ______________________________G Chapman, RN. Evaluation. Relate the pulse rate to other vital signs. Relate the pulse rhythm to baseline data and health status. Report to the primary care provider any abnormal findings such as irregular rhythm, reduced ability to hear the heartbeat, pallor, cyanosis, dyspnea, tachycardia, or bradycardia. Conduct appropriate follow-up such as administering medication ordered based on apical heart rate. Apical radial pulse assessment. An apical radial pulse may need to be assessed for clients with certain cardiovascular disorders. Normally, the apical and radial rates are identical. An apical pulse rate greater than a radial pulse rate can indicate that the thrust of the blood from the heart is too weak for the wave to be felt at the peripheral pulse site, or it can indicate that vascular disease is preventing impulses from being transmitted. Any discrepancy between the two pulse rates is called a pulse deficit and needs to be reported promptly. In no instance is the radial pulse greater than the apical pulse. An apical radial pulse can be taken by 2 nurses or 1 nurse, although the 2-nurse technique may be more accurate. Skill 29-4 outlines the steps for assessing an apical radial pulse. Lifespan considerations. Pulse. Infants use the apical pulse for the heart rate of newborns, infants, and children 2 to 3 years old to establish baseline data for subsequent evaluation, to determine whether the cardiac rate is within normal range, and to determine if the rhythm is regular. Place a baby in a supine position, and offer a pacifier if the baby is crying or restless. Crying and physical activity will increase the pulse rate. For this reason, take the resting apical pulse rate of infants and small children before assessing body temperatures. Locate the apical pulse in the left fourth intercostal space, lateral to the midclavicular line during infancy. Brachial, popliteal, and femoral pulses may be palpated. Due to a normally low blood pressure and rapid heart rate, infants' other distal pulses may be hard to feel. Newborn infants may have heart murmurs that are not pathologic, but reflect functional incomplete closure of fetal heart. Structures, ductus arteriosus or foramen ovale. Children. To take a peripheral pulse, position the child comfortably in the adult's arms or have the adult remain close by. This may decrease anxiety and yield more accurate results. To assess the apical pulse, assist a young child to a comfortable supine or sitting position. Demonstrate the procedure to the child using a stuffed animal or doll, and allow the child to handle the stethoscope before beginning the procedure. This will decrease anxiety and promote cooperation. The apex of the heart is normally located in the left fourth intercostal space in young children, fifth intercostal space in children 7 years of age and over, between the MCL and the anterior axillary line, see figure 29-14. Count the pulse prior to other uncomfortable procedures so that the rate is not artificially elevated by the discomfort. Older adults. If the client has severe hand or arm tremors, the radial pulse may be difficult to count. Cardiac changes in older adults, such as decrease in cardiac output, sclerotic changes to heart valves, and dysrhythmias, may suggest that obtaining an apical pulse will be more accurate than a peripheral pulse. Older adults often have decreased peripheral circulation. To detect these, pedal pulses should also be checked for regularity, volume, and symmetry. The pulse returns to baseline after exercise more slowly than with other age groups. M29B_Berm 4360-10_SE_CH29.IND 494 February 12, 14. 5:51 p.m. Number 153613 CUST, Pearson, Berman PG Number 495 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K short/Normal Design Services of S4 Carlisle Publishing Services. Assessing an apical radial pulse. Skill 29 to 4 Assessment. Assess clinical signs of hypovolemic shock, hypotension, pallor, cyanosis, and cold, clammy skin. Planning delegation. UAP are generally not responsible for assessing apical radial pulses using the one-nurse technique. UAP may perform the radial pulse count for the two-nurse technique. Interprofessional practice. Assessing an apical radial pulse may be within the scope of practice for many healthcare providers. Any provider who assesses a pulse can serve as the second person in the two-person technique. Equipment: clock or watch with a sweep, second hand or digital seconds indicator, stethoscope, antiseptic wipes. Implementation preparation. If using the two-nurse technique, ensure that the other nurse is available at this time. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Position the client appropriately. Assist the client to a comfortable supine or sitting position. Expose the area of the chest over the apex of the heart. If previous measurements were taken, determine what position the client assumed and use the same position. Rationale: this ensures an accurate comparative measurement. 5. Locate the apical and radial pulse sites. In the two-nurse technique, one nurse locates the apical impulse by palpation or with the stethoscope, while the other nurse palpates the radial pulse site. See skills 29-2 and 29-3. 6. Count the apical and radial pulse rates. Two-nurse technique: place the clock or watch where both nurses can see it. The nurse who is taking the radial pulse may hold the watch. Decide on a time to begin counting. A time when the second hand is on 12, 3, 6, or 9, or an even number on digital clocks is usually selected. The nurse taking the radial pulse says start. Rationale: this ensures that simultaneous counts are taken. Each nurse counts the pulse rate for 60 seconds. Both nurses end the count when the nurse taking the radial pulse says stop. Rationale: a full 60-second count is necessary for accurate assessment of any discrepancies between the two pulse sites. The nurse who assesses the apical rate also assesses the apical pulse rhythm and volume, i.e., whether the heartbeat is strong or weak. If the pulse is irregular, note whether the irregular beats come at random or at predictable times. The nurse assessing the radial pulse rate also assesses the radial pulse rhythm and volume. One nurse technique: within a few minutes, assess the apical pulse for 60 seconds and assess the radial pulse for 60 seconds. 7. Document the apical and radial, AR, pulse rates, rhythm, volume, and any pulse deficit in the client record. Also record related data such as variation in pulse rate compared to normal for the client, and other pertinent observations, such as pallor, cyanosis, or dyspnea. Evaluation: relate pulse rate and rhythm to other vital signs, to baseline data, and to general health status. Report to the primary care provider any changes from previous measurements, or any discrepancy between the two pulse rates. Purpose: to determine adequacy of peripheral circulation or presence of pulse deficit. Home care considerations: pulse. Assist in obtaining and using an electronic pulse measuring device if indicated. Teach the client to monitor the pulse prior to taking medications that affect the heart rate. Tell the client to report any notable changes in heart rate or rhythm, regularity, to the healthcare provider. Inform the client/family of activities known to significantly affect pulse rate, such as emotional stress, exercise, ingesting caffeine, and sleep. Clients sensitive to pulse rate changes should consider whether any of these activities should be modified in order to stabilize the pulse. Some clients require lengthy monitoring of the pulse and cardiac pattern, electrocardiogram. A special device, often referred to as a Holter monitor, is used for this type of monitor ing. It is usually applied in an office or clinic setting, and the client wears the portable recorder for 24 hours. Other portable devices used for recording episodic arrhythmias include cardiac event monitors. The client activates the device during times when symptoms appear, and then the recorded data can be transmitted to a central location through a telephone. Patient-centered care. 495. M29B_Berm 4362_10_SE_CH29.IND 495 February 12, 14, 5:51 p.m. 496 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 496 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Drug Capsule. Client with cardiac medications that affect heart rate. Cardiac glycosides increase cardiac contractility, which increases cardiac output. As a result, perfusion to the kidneys is increased, which increases the production of urine. Cardiac glycosides also decrease heart rate by prolonging cardiac conduction, especially at the AV node. Digoxin is commonly used for the clinical management of heart failure, atrial fibrillation, atrial flutter, and paroxysmal atrial tachycardia. Nursing responsibilities: take the apical pulse for 1 minute before administering the dose. If the apical pulse is 60 beats/min, or another specific parameter set by the healthcare provider, do not administer the dose and retake the pulse in 1 hour. If pulse remains 60, call the prescriber. Note, if the initial resting pulse is significantly 60, or the client has symptoms of bradycardia such as dizziness, notify the primary care provider without waiting to retake. Monitor electrolyte levels. Low potassium and low magnesium and high levels of calcium place the client at risk for digitalis toxicity. Check the client's most recent electrolyte laboratory work for safe levels before administering the dose. Avoid giving with meals because this will delay absorption. Monitor for therapeutic drug levels, 0.5 to 2 nanograms per milliliter. Digoxin has a narrow therapeutic index, which means that there is not much difference between a therapeutic effect and a toxic effect. Assess for signs of digoxin toxicity: anorexia, nausea, vomiting, diarrhea, blurred or yellow vision, unusual tiredness and weakness. Client and family teaching: explain the reason for taking digoxin and the importance of medical checkups that may include laboratory work to evaluate the effects and dosage of the drug. Teach the client and/or family how to check the radial or carotid pulse for a full minute. Inform them to take the pulse at the same time each day and to write it on the calendar. Provide pulse parameters and tell them when it is appropriate to call the healthcare provider. Caution the client not to stop taking the digoxin without approval of the healthcare provider. Caution the client to avoid over-the-counter drugs, except on the advice of the healthcare provider, because many can interact with digoxin. Explain the signs and symptoms of digoxin toxicity and the importance of calling the healthcare provider. Note: prior to administering any medication, review all aspects with a current drug handbook or other reliable source. Cardiac glycoside or digitalis glycoside digoxin, linoxin. Respirations. Respiration is the act of breathing. Inhalation or inspiration refers to the intake of air into the lungs. Exhalation or expiration refers to breathing out, or the movement of gases from the lungs to the atmosphere. Ventilation is also used to refer to the movement of air in and out of the lungs. There are basically two types of breathing: costal, thoracic breathing, and diaphragmatic, abdominal breathing. Costal breathing involves the external intercostal muscles and other accessory muscles, such as the sternocleidomastoid muscles. It can be observed by the movement of the chest upward and outward. By contrast, diaphragmatic breathing involves the contraction and relaxation of the diaphragm, and it is observed by the movement of the abdomen, which occurs as a result of the diaphragm's contraction and downward movement. Mechanics and regulation of breathing. During inhalation, the following processes normally occur. Figure 29 to 16. The diaphragm contracts, flattens, the ribs move upward and outward, and the sternum moves outward, thus enlarging the thorax and permitting the lungs to expand. During exhalation, figure 29 to 17, the diaphragm relaxes, the ribs move downward and inward, and the sternum moves inward, thus decreasing the size of the thorax as the lungs are compressed. Normal breathing is automatic and effortless. A normal adult inspiration lasts 1 to 1.5 seconds, and an expiration lasts 2 to 3 seconds. Respiration is controlled by A. Respiratory centers in the medulla oblongata and the pons of the brain, and B. Chemoreceptors located centrally in the medulla and peripherally in the carotid and aortic bodies. These centers and receptors respond to changes in the concentrations of oxygen, O2, carbon dioxide, CO2, and hydrogen, H+, in the arterial blood. See Chapter 50 for details. Sternum moves outward. Diaphragm contracts. Diaphragm contracts. Ribs move upward and outward. Figure 29 to 16. Respiratory inhalation. Top, lateral view, bottom, anterior view. M29B_Berm 4362_10_SE_CH29.IND496 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 497. Number 153613 CUST, Pearson, Berman PG Number 497 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Inspiration and expiration. An adult takes in about 500 ml of air. This volume is called the tidal volume. For further information about pulmonary volumes and pulmonary capacities, see Chapter 50. Body position also affects the amount of air that can be inhaled. People in a supine position experience two physiological processes that suppress respiration: an increase in the volume of blood inside the thoracic cavity and compression of the chest. Consequently, clients lying on their back have poorer lung aeration, which predisposes them to the stasis of fluids and subsequent infection. Certain medications also affect the respiratory depth. For example, narcotics such as morphine and large doses of barbiturates such as pentobarbital depress the respiratory centers in the brain, thereby depress the respiratory rate and depth. Hyperventilation refers to very deep, rapid respirations. Hypoventilation refers to very shallow respirations. Respiratory rhythm refers to the regularity of the expirations and the inspirations. Normally, respirations are evenly spaced. Respiratory rhythm can be described as regular or irregular. An infant's respiratory rhythm may be less regular than an adult's. See Chapter 50 for details about abnormal respiratory rhythms. Respiratory quality or character refers to those aspects of breathing that are different from normal, effortless breathing. Two of these aspects are the amount of effort a client must exert to breathe, and the sound of breathing. Usually, breathing does not require noticeable effort. Sometimes, however, clients can breathe only with substantial effort. This is referred to as labored breathing. The sound of breathing is also significant. Normal breathing is silent, but a number of abnormal sounds such as a wheeze are obvious to the nurse's ear. Many sounds occur as a result of the presence of fluid in the lungs, and are most clearly heard with a stethoscope. See Chapter 30 for methods used to assess lung sounds. For details about altered breathing patterns and terms used to describe various patterns and sounds, see box 29 to 5. The effectiveness of respirations is measured in part by the uptake of oxygen from the air into the blood, and the release of carbon dioxide from the blood into expired air. The amount of hemoglobin in arterial blood that is saturated with oxygen can be measured indirectly through pulse oximetry. A pulse oximeter provides a digital readout of both the client's pulse rate and the oxygen saturation. See Skill 29 to 7 later in this chapter. Skill 29-5 outlines the steps for assessing respirations. Assessing respirations. Resting respirations should be assessed when the client is relaxed because exercise affects respirations, increasing their rate and depth. Anxiety is likely to affect respiratory rate and depth as well. Respirations may also need to be assessed after exercise to identify the client's tolerance to activity. Before assessing a client's respirations, a nurse should be aware of the following: the client's normal breathing pattern, the influence of the client's health problems on respirations, any medications or therapies that might affect respirations, the relationship of the client's respirations to cardiovascular function. The rate, depth, rhythm, quality, and effectiveness of respirations should be assessed. The respiratory rate is normally described in breaths per minute. Breathing that is normal in rate and depth is called eupnea. Abnormally slow respirations are referred to as bradypnea, and abnormally fast respirations are called tachypnea or polypnea. Apnea is the absence of breathing. For the respiratory rates for different age groups, see Table 29-2 on page 487. Clinical alert. An adult sleeping client's respirations can fall to fewer than 10 shallow breaths per minute. Use other vital signs to validate the client's condition. Factors affecting respirations. Several factors influence respiratory rate. Those that increase the rate include exercise, increases metabolism, stress, readies the body for fight or flight, increased environmental temperature, and lowered oxygen concentration at increased altitudes. Factors that may decrease the respiratory rate include decreased environmental temperature, certain medications, example, narcotics, and increased intracranial pressure. The depth of a person's respirations can be established by watching the movement of the chest. Respiratory depth is generally described as normal, deep, or shallow. Deep respirations are those in which a large volume of air is inhaled and exhaled, inflating most of the lungs. Shallow respirations involve the exchange of a small volume of air, and often the minimal use of lung tissue. During a normal, sternum moves inward. Diaphragm relaxes. Diaphragm relaxes. Ribs move downward and inward. Figure 29-17 respiratory exhalation, left, lateral view, right, anterior view. M29B_Berm 4362_10_SE_CH29.IND 497 February 12, 5:51 p.m. 498 Unit 7 Assessing Health. Number 153613 CUST, Pearsono, Berman PG Number 498 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Box 29-5 Altered Breathing Patterns and Sounds. Breathing patterns. Rate: tachypnea, quick, shallow breaths; bradypnea, abnormally slow breathing; apnea, cessation of breathing; volume: hyperventilation, overexpansion of the lungs characterized by rapid and deep breaths; hypoventilation, underexpansion of the lungs, characterized by shallow respirations; rhythm: Cheyne-Stokes breathing, rhythmic waxing and waning of respirations, from very deep to very shallow breathing; and temporary apnea, ease or effort; dyspnea, difficult and labored breathing during which the individual has a persistent, unsatisfied need for air and feels distressed; orthopnea, ability to breathe only in upright sitting or standing positions. Breath sounds audible without amplification. Stridor, a shrill, harsh sound heard during inspiration with laryngeal obstruction. Stertor, snoring or sonorous respiration, usually due to a partial obstruction of the upper airway. Wheeze, continuous, high-pitched musical squeak or whistling sound occurring on expiration, and sometimes on inspiration when air moves through a narrowed or partially obstructed airway. Bubbling, gurgling sounds heard as air passes through moist secretions in the respiratory tract. Chest movements. Intercostal retraction, indrawing between the ribs; substernal retraction, indrawing beneath the breastbone; suprasternal retraction, indrawing above the clavicles. Secretions and coughing. Hemoptysis, the presence of blood in the sputum productive cough, a cough accompanied by expectorated secretions non-productive cough, a dry, harsh cough without secretions. Purposes to acquire baseline data, against which future measurements can be compared to monitor abnormal respirations and respiratory patterns and identify changes to monitor respirations before or after the administration of a general anesthetic or any medication that influences respirations. To monitor clients at risk for respiratory alterations, example, those with fever, pain, acute anxiety, chronic obstructive pulmonary disease, asthma, respiratory infection, pulmonary edema, or emboli, chest trauma or constriction, brainstem injury. Assessment: assess skin and mucous membrane color, example, cyanosis or pallor, position assumed for breathing, example, use of orthopneic position, signs of lack of oxygen to the brain, example, irritability, restlessness, drowsiness, or loss of consciousness, chest movements, example, retractions between the ribs or above or below the sternum. Activity tolerance: chest pain, dyspnea, medications affecting respiratory rate. Planning delegation. Counting and observing respirations may be delegated to UAP. The follow-up assessment, interpretation of abnormal respirations, and determination of appropriate responses are done by the nurse. Interprofessional practice. Assessing respirations may be within the scope of practice for many healthcare providers. For example, in addition to nurses, respiratory therapists will check the client's breathing before, during, and after treatment. Although these therapists may verbally communicate their findings and plan to the healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment: clock or watch with a sweep, second hand or digital seconds indicator. Implementation: preparation for a routine assessment of respirations. Determine the client's active ITY schedule, and choose a suitable time to monitor the respirations. A client who has been exercising will need to rest for a few minutes to permit the accelerated respiratory rate to return to normal. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. Assessing respirations. Skill 29-5. M29B_Berm 4362_10_SE_CH29.IND 498 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 499. Number 153613 CUST, Pearson O. Berman PG Number 499 Title, Cozier and Herb's Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. Assessing respirations, continued. Skill 29-5. 4. Observe or palpate and count the respiratory rate. The client's awareness that the nurse is counting the respiratory rate could cause the client to purposefully alter the respiratory pattern. If you anticipate this, place a hand against the client's chest to feel the chest movements with breathing, or place the client's arm across the chest and observe the chest movements while supposedly taking the radial pulse. Count the respiratory rate for 30 seconds if the respirations are regular. Count for 60 seconds if they are irregular. An inhalation and an exhalation count as one respiration. 5. Observe the depth, rhythm, and character of respirations. Observe the respirations for depth by watching the movement of the chest. Rationale: during deep respirations, a large volume of air is exchanged. During shallow respirations, a small volume is exchanged. Observe the respirations for regular or irregular rhythm. Rationale: normally, respirations are evenly spaced. Observe the character of respirations, the sound they produce, and the effort they require. Rationale: normally, respirations are silent and effortless. 6. Document the respiratory rate, depth, rhythm, and character on the appropriate record, see in Skill 29-1. Sample documentation. May 17, 16 13 20 respirations irregular, from 18:34/min in past hour. Shallower respirations during tachypnea. Inspiratory wheeze noted. Respiratory therapist called to provide treatment. D. Cadano, RN. Evaluation. Relate respiratory rate to other vital signs, in particular pulse rate. Relate respiratory rhythm and depth to baseline data and health status. Report to the primary care provider a respiratory rate significantly above or below the normal range and any notable change in respirations from previous assessments, irregular respiratory rhythm, inadequate respiratory depth, abnormal character of breathing, orthopnea, wheezing, stridor, or bubbling, and any complaints of dyspnea. Lifespan considerations. Respirations. Infants and children. An infant or child who is crying will have an abnormal respiratory rate and rhythm and needs to be quieted before respirations can be accurately assessed. Infants and young children use their diaphragms for inhalation and exhalation. If necessary, place your hand gently on the infant's abdomen to feel the rapid rise and fall during respirations. Most newborns are complete nose breathers, so nasal obstruction can be life-threatening. Some newborns display periodic breathing in which they pause for a few seconds between respirations. This condition can be normal, but parents should be alert to prolonged or frequent pauses, apnea, that require medical attention. Compared to adults, infants have fewer alveoli, and their airways have a smaller diameter. As a result, infants' respiratory rate and effort of breathing will increase with respiratory infections. Count respirations prior to other uncomfortable procedures, so that the respiratory rate is not artificially elevated by the discomfort. Older adults ask the client to remain quiet or count respirations after taking the pulse. Older adults experience anatomic and physiological changes that cause the respiratory system to be less efficient. Any changes in rate or type of breathing should be reported immediately. Blood pressure. Arterial blood pressure is a measure of the pressure exerted by the blood as it flows through the arteries. Because the blood moves in waves, there are two blood pressure measurements. The systolic pressure is the pressure of the blood as a result of contraction of the ventricles, that is, the pressure of the height of the blood wave. The diastolic pressure is the pressure when the ventricles are at rest. Diastolic pressure, then, is the lower pressure, present at all times within the arteries. The difference between the diastolic and the systolic pressures is called the pulse pressure. A normal pulse pressure is about 40 mmHg, but can be as high as 100 mmHg during exercise. Blood pressure is measured in millimeters of mercury, mmHg, and recorded as a fraction, systolic pressure over the diastolic pressure. A typical blood pressure for a healthy adult is 120/80 mmHg, pulse pressure of 40. Because blood pressure can vary considerably among individuals, it is important for the nurse to know a specific client's baseline blood pressure. For example, if a client's usual blood pressure is 180/100 mmHg, and it is assessed following surgery to be 120/80 mmHg, this significant drop in pressure may indicate comply cations and must be reported to the primary care provider. A consistently elevated pulse pressure occurs in arteriosclerosis. A low pulse pressure, example, less than 25 mmHg, occurs in conditions such as severe heart failure. Sometimes, it is useful to also determine the mean arterial pressure, MAP, because this represents the home care considerations. Respirations. Monitor respiratory rate following the administration of respiratory depressants, such as morphine. Assess the home setting for factors that could interfere with breathing, such as exhaust, gas, or paint fumes, or individuals who smoke. If the client has just come in from another room, allow the client to rest a minute or two before counting respirations. Have an adult hold a child gently to reduce movement while counting respirations. Safety. M29B_Berm 4362_10_SE_CH29. 499 February 12, 14, 5:51 p.m. 500 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG Number 500 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Pressure actually delivered to the body's organs. The map can be calculated in several different ways, one of which is to add 2/3 of the diastolic pressure to 1/3 of the systolic pressure. A normal map is 70 to 110 mmHg. Determinants of blood pressure. Arterial blood pressure is the result of several factors: the pumping action of the heart, the peripheral vascular resistance, the resistance supplied by the blood vessels through which the blood flows, and the blood volume and viscosity. Pumping action of the heart. When the pumping action of the heart is weak, less blood is pumped into arteries, lower cardiac output, and the blood pressure decreases. When the heart's pumping action is strong, and the volume of blood pumped into the circulation increases, higher cardiac output, the blood pressure increases. Peripheral vascular resistance. Peripheral resistance can increase blood pressure. The diastolic pressure especially is affected. Some factors that create resistance in the arterial system are the capacity of the arterioles and capillaries, the compliance of the arteries, and the viscosity of the blood. The internal diameter or capacity of the arterioles and the capillaries determines in great part the peripheral resistance to the blood in the body. The smaller the space within a vessel, the greater the resistance. Normally, the arterioles are in a state of partial constriction. Increased vasoconstriction, such as occurs with smoking, raises the blood pressure, whereas decreased vasoconstriction lowers the blood pressure. If the elastic and muscular tissues of the arteries are replaced with fibrous tissue, the arteries lose much of their ability to constrict and dilate. This condition, most common in middle-aged and older adults, is known as arteriosclerosis. Blood volume. When the blood volume decreases, for example, as a result of a hemorrhage or dehydration, the blood pressure decreases because of decreased fluid in the arteries. Conversely, when the volume increases, for example, as a result of a rapid intravenous infusion, the blood pressure increases because of the greater fluid volume within the circulatory system. Blood viscosity. Blood pressure is higher when the blood is highly viscous, thick, that is, when the proportion of red blood cells to the blood plasma is high. This proportion is referred to as the hematocrit. The viscosity increases markedly when the hematocrit is more than 60% to 65%. Factors affecting blood pressure. Among the factors influencing blood pressure are age, exercise, stress, race, gender, medications, obesity, diurnal variations, medical conditions, and temperature. Age. Newborns have a systolic pressure of about 75 mmHg. The pressure rises with age, reaching a peak at the onset of puberty, and then tends to decline somewhat. In older adults, elasticity of the arteries is decreased. The arteries are more rigid and less yield to the pressure of the blood. This produces an elevated systolic pressure. Because the walls no longer retract as flexibly with decreased pressure, the diastolic pressure may also be high. Exercise. Physical activity increases the cardiac output and hence the blood pressure. For reliable assessment of resting blood pressure, wait 20 to 30 minutes following exercise. Stress. Stimulation of the sympathetic nervous system increases cardiac output and vasoconstriction of the arterioles, thus increasing the blood pressure reading. However, severe pain can decrease blood pressure greatly by inhibiting the vasomotor center and producing vasodilation. Race. African Americans older than 35 years tend to have higher blood pressures than European Americans of the same age, although the exact reasons for these differences are unclear. Covelli, Wood, and Urandi, 2012. Sex. After puberty, females usually have lower blood pressures than males of the same age. This difference is thought to be due To hormonal variations. After menopause, women generally have higher blood pressures than before. Medications. Many medications, including caffeine, may increase or decrease the blood pressure. Obesity. Both childhood and adult obesity predispose to hypertension. Diurnal variations. Pressure is usually lowest early in the morning, when the metabolic rate is lowest, then rises throughout the day, and peaks in the late afternoon or early evening. Medical conditions. Any condition affecting the cardiac output, blood volume, blood viscosity, and/or compliance of the arteries has a direct effect on the blood pressure. Temperature. Because of increased metabolic rate, fever can increase blood pressure. However, external heat causes vasodilation and decreased blood pressure. Cold causes vasoconstriction and elevates blood pressure. Hypertension. A blood pressure that is persistently above normal is called hypertension. A single elevated blood pressure reading indicates the need for reassessment. Hypertension cannot be diagnosed unless an elevated blood pressure is found when measured twice at different times. It is usually asymptomatic and is often a contributing factor to myocardial infarctions, heart attacks. An elevated blood pressure of unknown cause is called primary hypertension. An elevated blood pressure of known cause is called secondary hypertension. Hypertension is a widespread health problem. Individuals with diastolic blood pressures of 80 to 89 mmHg or systolic blood pressures of 120 to 139 mmHg should be considered prehypertensive and, without intervention, may develop cardiac disease. Hypertension is when either the systolic BP is higher than 140 mmHg or when the diastolic blood pressure, BP, is 90 mmHg or higher, see Table 29-4. The stage of hypertension is determined by the higher of the two values. For example, if either of the systolic or diastolic values falls in the stage 2 range, stage 2 hypertension is assigned. Factors associated with hypertension include thickening of the arterial walls, which reduces the size of the arterial lumen, and inelasticity of the arteries, as well as such lifestyle factors as cigarette smoking, obesity, heavy alcohol consumption, lack of physical exercise, high blood cholesterol levels, and continued exposure to stress. The national guidelines for high blood pressure management recommend that hypertensive individuals age 60 years or older. M29B_BERM 4362_10_SE_CH29.IND 500 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 501. Number 153613 CUST, Pearson O. Berman PG Number 501 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Receive treatment toward a goal of less than 150/90 mmHg, and hypertensive individuals age 30 through 59 years have a diastolic goal of less than 90 mmHg. For all other individuals, the goal is less than 140/90 mmHg. James et al., 2014. Hypotension. Hypotension is a blood pressure that is below normal, that is, a systolic reading consistently between 85 and 110 mmHg in an adult whose normal pressure is higher than this. Orthostatic hypotension is a blood pressure that decreases when the client sits or stands. It is usually the result of peripheral vasodilation, in which blood leaves the central body organs, especially the brain, and moves to the periphery, often causing the person to feel faint. Hypotension can also be caused by analgesics such as meperidine hydrochloride, Demerol, bleeding, severe burns, and dehydration. It is important to monitor hypotensive clients carefully to prevent falls. When assess ING for orthostatic hypotension. Place the client in a supine position for 10 minutes. Record the client's blood pressure. Assist the client to slowly sit or stand. Support the client in case of faintness. Immediately recheck the blood pressure in the same sites as previously. Repeat the pulse and blood pressure after 3 minutes. Record the results. A drop in blood pressure of 20 mmHg systolic or 10 mmHg diastolic indicates orthostatic hypotension, major, 2012. Assessing blood pressure. Blood pressure is measured with a blood pressure cuff, a sphygmomanometer, and a stethoscope. The blood pressure cuff consists of a bag, called a bladder, that can be inflated with air, figure 29 to 18. It is covered with cloth and has 2 tubes attached to it. One tube connects to a bulb that inflates the bladder. A small valve on the side of this bulb traps and releases the air in the bladder. The other tube is attached to a sphygmomanometer. The sphygmomanometer indicates the pressure of the air within the bladder. There are 2 types of sphygmomanometers, aneroid and digital. The aneroid sphygmomanometer has a calibrated dial, with a needle that points to the calibrations, figure 29 to 19. Many agencies use digital, electronic, sphygmomanometers, figure 29 to 20, which eliminate the need to listen for the sounds of the client's systolic and diastolic blood pressures through cuff, valve, bulb, tube to sphygmomanometer. A. B. Bladder length. Cuff bladder. Bladder width. Figure 29 to 18A, blood pressure cuff and bulb. B. Bladder inside the cuff. Figure 29 to 19, blood pressure equipment, an aneroid manometer and cuff. A stethoscope. Electronic blood pressure devices should be calibrated periodically to check accuracy. All healthcare facilities should have manual blood pressure equipment available as backup. Doppler ultrasound stethoscopes are also used to assess blood pressure. See figure 29 to 15. These are of particular value when blood pressure sounds are difficult to hear, such as in infants, obese clients, and clients in shock. Systolic pressure may be the only blood pressure obtainable with some ultrasound models. Blood pressure cuffs come in various sizes, because the bladder must be the correct width and length for the client's arm, figure 29 to 21. If the bladder is too narrow, the blood pressure reading will be erroneously elevated. If it is too wide, the reading will be erroneously low. The width should be 40% of the circumference, or 20% wider than the diameter of the midpoint of the limb. Category: systolic BP, mmHg, diastolic BP, mmHg, normal 120 and 80, pre-hypertension 120 to 139 or 80 to 89, hypertension, stage 1 140 to 159 or 90 to 99, hypertension, stage 2 greater than 160 or 100 from the 7th report of the Joint National Committee for the Detection, Evaluation, and Treatment of High Blood Pressure, completed report by National Institutes of Health, National Heart, Lung, and Blood Institute, 2004. Retrieved from http://www.nhl.nih.gov/guidelines/hypertension/jnc7 full.htm. Table 29 to 4, classification of blood pressure. M29B_Berm 4362_10_SE_CH29.IND 501 February 12, 14, 5:51 p.m. 502 Unit 7, Assessing Health. Number 153613 CUST, Pearson, Berman PG. Number 502 Title, Cozier and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Blood pressure assessment cites the blood pressure is usually assessed in the client's upper arm using the brachial artery and a standard stethoscope. Assessing the blood pressure on a client's thigh is indicated in these situations. The blood pressure cannot be measured on either arm, example, because of burns or other trauma. The blood pressure in one thigh is to be compared with the blood pressure in the other thigh. Blood pressure is not measured on a particular client's limb in the following situations: the shoulder, arm, or hand, or the hip, knee, or ankle, is injured or diseased. A cast or bulky bandage is on any part of the limb. The client has had surgical removal of breast or axillary, or inguinal, lymph nodes on that side. The client has an intravenous infusion or blood transfusion in that limb. The client has an arteriovenous fistula, example, for renal dialysis, in that limb. Methods: blood pressure can be assessed directly or indirectly. Direct, invasive monitoring, measurement involves the insertion of a catheter into on which it is used. The arm circumference, not the age of the client, should always be used to determine bladder size. The nurse can determine whether the width of a blood pressure cuff is appropriate. Lay the cuff lengthwise at the midpoint of the upper arm, and hold the outermost side of the bladder edge laterally on the arm. With the other hand, wrap the width of the cuff around the arm, and ensure that the width is 40% of the arm circumference, figure 29 to 22. The length of the bladder also affects the accuracy of measurement. The bladder should be sufficiently long to cover at least 2/3 of the limb's circumference. For obese clients, a standard-sized bladder in an extra-long cuff may be the most appropriate. McFarlane, 2012. Blood pressure cuffs are made of non-distensible material, so that an even pressure is exerted around the limb. Most cuffs are held in place by hooks, snaps, or hook and loop fabric. Others have a cloth bandage that is long enough to encircle the limb several times. This type is closed by tucking the end of the bandage into one of the bandage folds. Finger sensor for pulse and O2 saturation. Thermometer. Digital display of systolic and diastolic BP, temperature, pulse, and O2 saturation. Figure 29 to 20 electronic blood pressure monitors register blood pressures. Figure 29 to 21 standard cuff sizes. Smaller cuffs are used for infants, small children, or frail adults. Mid-size cuffs are used for most adults, and larger cuffs are used for measuring the blood pressure on the leg or arm of an adult who is obese. Bladder of cuff. Figure 29 to 22 determining that the bladder of a blood pressure cuff is 40% of the arm circumference, or 20% wider than the diameter of the midpoint of the limb. M29B_Berm 4360-10_SE_CH29.IND 502 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 503. Number 153613 CUST, Pearson, Berman PG Number 503 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Particularly in hypertensive clients, is the temporary disappearance of sounds normally heard over the brachial artery when the cuff pressure is high, followed by the reappearance of the sounds at a lower level. This temporary disappearance of sounds occurs in the latter part of Phase 1 and Phase 2 and may cover a range of 40 mmHg. If a palpated estimation of the systolic pressure is not made prior to auscultation, the nurse may begin listening in the middle of this range and underestimate the systolic pressure. In the palpatory method of blood pressure determination, instead of listening for the blood flow sounds, the nurse uses light to moderate pressure to palpate the pulsations of the artery as the pressure in the cuff is released. The pressure is read from the sphygmomanometer when the first pulsation is felt. A single whip-like vibration, felt in addition to the pulsations, identifies the point at which the pressure in the cuff nears the diastolic pressure. This vibration is no longer felt when the cuff pressure is below the diastolic pressure. Common errors in assessing blood pressure. The importance of the accuracy of blood pressure assessments cannot be overemphasized. Many judgments about a client's health are made based on blood pressure. It is an important indicator of the client's condition and is used extensively as a basis for nursing interventions. Two possible reasons for blood pressure errors are hurrying on the part of the nurse and subconscious bias, in which a nurse may be influenced by the client's previous blood pressure measurements or diagnosis and hear a value consistent with the nurse's expectations. Some reasons for erroneous blood pressure readings are given in Table 29-5. Skill 29-6 provides guidelines for assessing blood pressure. The brachial, radial, or femoral artery. Arterial pressure is represented as wave-like forms displayed on a monitor. With correct placement, this pressure reading is highly accurate. Two non-invasive indirect methods of measuring blood pressure are the auscultatory and palpatory methods. The auscultatory method is most commonly used in hospitals, clinics, and homes. External pressure is applied to a superficial artery, and the nurse reads the pressure from the sphygmomanometer while listening with a stethoscope. When carried out correctly, the auscultatory method is relatively accurate. When taking a blood pressure using a stethoscope, the nurse identifies phases in the series of sounds called Korotkoff sounds, figure 29-23. 5 phases occur but may not always be audible, box 29-6. The systolic pressure is the point where the first tapping sound is heard, phase 1. In adults, the diastolic pressure is the point where the sounds become inaudible, phase 5. The phase 5 reading may be 0, that is, the muffled sounds are heard even when there is no air pressure in the blood pressure cuff. For complete accuracy, the phase 4 and 5 readings should be recorded. The palpatory method is sometimes used when Korotkoff sounds cannot be heard and electronic equipment to amplify the sounds is not available, or to prevent misdirection from the presence of an auscultatory gap. An auscultatory gap which occurs. Korotkoff phases. Phase 1. Phase 2. Phase 3. Phase 4. Phase 5. A sharp tapping. A swishing or whooshing sound. A thump softer than the tapping in phase 1. A softer blowing muffled sound that fades. Silence. 140. 130. 120. 110. 100. 90. 80. Figure 29-23 Korotkoff sounds can be differentiated into 5 phases. In the illustration the blood pressure is 138/90 or 138/102/90. Box 29-6 Korotkoff sounds. Phase 1, the pressure level at which the first faint, clear tapping or thumping sounds are heard. These sounds gradually become more intense. To ensure that they are not extraneous sounds, the nurse should identify at least 2 consecutive tapping sounds. The first tapping sound heard during deflation of the cuff is the systolic blood pressure. Phase 2, the period during deflation when the sounds have a muffled, whooshing, or swishing quality. Phase 3, the period during which the blood flows freely through an increasingly open artery, and the sounds become crisper and more intense, and again assume a thumping quality, but softer than in phase 1. Phase 4, the time when the sounds become muffled and have a soft, blowing quality. Phase 5, the pressure level when the last sound is heard. This is followed by a period of silence. The pressure at which the last sound is heard is the diastolic blood pressure in adults, asterisk. Asterisk in agencies where the 4th phase is considered the diastolic pressure, 3 measures are recommended, systolic pressure, diastolic pressure, and phase 5. These may be referred to as systolic, first diastolic, and second diastolic pressures. The phase 5, second diastolic pressure, reading may be 0, that is, the muffled sounds are heard even when there is no air pressure in the blood pressure cuff. In some instances, muffled sounds are never heard, in which case a dash is inserted where the reading would normally be recorded, example, //110. M29B_berm 4362_10_SE_CH29.IND 503 February 12, 14, 5:51 p.m. 504 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 504 Title, Cozier, and herbs fundamentals of nursing 10 EC/M/Y/K/normal design services of S4 Carlisle Publishing Services. Table 29 to 5 selected sources of error in blood pressure assessment. Error effect: bladder cuff too narrow, erroneously high. Bladder cuff too wide, erroneously low. Arm unsupported, erroneously high. Insufficient rest before the assessment, erroneously high. Repeating assessment too quickly, erroneously high systolic or low diastolic readings. Cuff wrapped too loosely or unevenly, erroneously high. Deflating cuff too quickly, erroneously low systolic and high diastolic readings. Deflating cuff too slowly, erroneously high diastolic reading. Failure to use the same arm consistently, inconsistent measurements. Arm above level of the heart, erroneously low. Assessing immediately after a meal, or while client smokes, or has pain, erroneously high. Failure to identify auscultatory gap, erroneously low systolic pressure, and erroneously low diastolic pressure. Purpose: to obtain a baseline measurement of arterial blood pressure for subsequent evaluation to determine the client's hemodynamic status, example, cardiac output, stroke volume of the heart, and blood vessel resistance. To identify and monitor changes in blood pressure resulting from a disease process or medical therapy, example, presence or history of cardiovascular disease, renal disease, circulatory shock, or acute pain, rapid infusion of fluids or blood products. Assessment: assess signs and symptoms of hypertension, example, headache, ringing in the ears, flushing of face, nosebleeds, fatigue, signs and symptoms of hypertension, example, tachycardia, dizziness, mental confusion, restlessness, cool and clammy skin, pale or cyanotic skin. Factors affecting blood pressure, example, activity, emotional stress, pain, and time the client last smoked or ingested caffeine. Some blood pressure cuffs contain latex. Assess the client for latex allergy and obtain a latex-free cuff if indicated. Planning delegation. Blood pressure measurement may be delegated to UAP. The interpretation of abnormal blood pressure readings and determination of appropriate responses are done by the nurse. Interprofessional practice. Measurement of blood pressure is within the scope of practice for many healthcare providers. For example, in addition to nurses, therapists may check the client's blood pressure before, during, and after treatment. Although these therapists may verbally communicate their findings and plan to the healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment: stethoscope or DUS blood pressure cuff of the appropriate size, sphygmomanometer. Implementation preparation 1. Ensure that the equipment is intact and functioning properly. Check for leaks in the tubing between the cuff and the sphygmomanometer. 2. Make sure that the client has not smoked or ingested caffeine within 30 minutes prior to measurement. Rationale: smoking constricts blood vessels, and caffeine increases the pulse rate. Both of these cause a temporary increase in blood pressure. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Position the client appropriately. The adult client should be sitting unless otherwise specified. Both feet should be flat on the floor. Rationale: legs crossed at the knee results in elevated systolic and diastolic blood pressures. Pinar, Atalkin, and Watson, 2010. Assessing blood pressure. Skill 29, 6. M29B_Berm 4362_10_SE_CH29.IND 504 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 505. Number 153613 CUST, Pearsoneau, Berman PG No. 505 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing blood pressure, continued. Skill 29-6. The elbow should be slightly flexed with the palm of the hand facing up, and the arm supported at heart level. Readings in any other position should be specified. The blood pressure is normally similar in sitting, standing, and lying positions, but it can vary significantly by position in certain persons. Rationale: the blood pressure increases when the arm is below heart level and decreases when the arm is above heart level. Expose the upper arm. 5. Wrap the deflated cuff evenly around the upper arm. Locate the brachial artery, see Figure 29-13, page 487. Apply the center of the bladder directly over the artery. Rationale: the bladder inside the cuff must be directly over the artery to be compressed if the reading is to be accurate. For an adult, place the lower border of the cuff approximately 2.5 centimeters 1 inch above the antecubital space. 6. If this is the client's initial examination, perform a preliminary palpatory determination of systolic pressure. Rationale: the initial estimate tells the nurse the maximal pressure to which the sphygmomanometer needs to be elevated in subsequent determinations. It also prevents underestimation of the systolic pressure or overestimation of the diastolic pressure, should an auscultatory gap occur. Palpate the brachial artery with the fingertips. Close the valve on the bulb. Pump up the cuff until you no longer feel the brachial pulse. At that pressure the blood cannot flow through the artery. Note the pressure on the sphygmomanometer at which pulse is no longer felt. Rationale: this gives an estimate of the systolic pressure. Release the pressure completely in the cuff, and wait 1 to 2 minutes before making further measurements. Rationale: a waiting period gives the blood trapped in the veins time to be released. Otherwise, false high systolic readings will occur. 7. Position the stethoscope appropriately. Cleanse the earpieces with antiseptic wipe. Insert the ear attachments of the stethoscope in your ears so that they tilt slightly forward. Rationale: sounds are heard more clearly when the ear attachments follow the direction of the ear canal. Ensure that the stethoscope hangs freely from the ears to the diaphragm. Rationale: if the stethoscope tubing rubs against an object, the noise can block the sounds of the blood within the artery. Place the bell side of the amplifier of the stethoscope over the brachial pulse site. Rationale: because the blood pressure is a low-frequency sound, it is best heard with the bell-shaped diaphragm. Place the stethoscope directly on the skin, not on clothing over the site. Rationale: this is to avoid noise made from rubbing the amplifier against cloth. Hold the diaphragm with the thumb and index finger. 8. Auscultate the client's blood pressure. Pump up the cuff until the sphygmomanometer reads 30 mmHg above the point where the brachial pulse disappeared. Release the valve on the cuff carefully so that the pressure decreases at the rate of 2 to 3 mmHg per second. Rationale: if the rate is faster or slower, an error in measurement may occur. As the pressure falls, identify the manometer reading at Korotkoff phases 1, 4, and 5. Rationale: there is no clinical significance to phases 2 and 3. Deflate the cuff rapidly and completely. Wait 1 to 2 minutes before making further determinations. Rationale: this permits blood trapped in the veins to be released. Repeat the above steps to confirm the accuracy of the reading, especially if it falls outside the normal range, although this may not be routine procedure for hospitalized or well clients. If there is greater than 5 mmHg difference between the two readings, additional measurements may be taken and the results averaged. 9. If this is the client's initial examination, repeat the procedure on the client's other arm. There should be a difference of no more than 10 mmHg between the arms. The arm found to have the higher pressure should be used for subsequent examinations. Fonseca Reyes, Forsyth McQuarrie, and Garcia de Alba Garcia, 2012. Variation: obtaining a blood pressure by the palpation method if it is not possible to use a stethoscope to obtain the blood pressure. Sure, or if the Korotkoff sounds cannot be heard, palpate the radial or brachial pulse site as the cuff pressure is released. The manometer reading at the point where the pulse reappears is an estimate of systolic value. Variation: taking a thigh blood pressure help the client to assume a prone position. If the client cannot assume this position, measure the blood pressure while the client is in a supine position with the knee slightly flexed. Slight flexing of the knee will facilitate placing the stethoscope on the popliteal space. Expose the thigh, taking care not to expose the client unduly. Locate the popliteal artery, see figure 29 to 13. Wrap the cuff evenly around the mid-thigh with the compression bladder over the posterior aspect of the thigh and the bottom edge above the knee. Rationale: the bladder must be directly over the posterior popliteal artery if the reading is to be accurate. If this is the client's initial examination, perform a preliminary palpatory determination of systolic pressure by palpating the popliteal artery. In adults, the systolic pressure in the popliteal artery is usually 20 to 30 mmHg higher than that in the brachial artery. The diastolic pressure is usually the same. Variation: using an electronic indirect blood pressure monitoring device, see figure 29 to 20, page 502, place the blood pressure cuff on the extremity according to the manufacturer's guidelines. Turn on the blood pressure switch. Measuring blood pressure in a client's thigh. Continued on page 506. M29B_Berm 4362_10_SE_CH29.IND 505 February 12, 14, 5:51 p.m. 506 Unit 7 Assessing Health. Number 153613 CUST, Pearson Berman PG Number 506 Title, Cozier and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing blood pressure, continued. Skill 29 to 6. Evaluation: relate blood pressure to other vital signs, to baseline data, and to health status. If the findings are significantly different from previous values without obvious reasons, consider possible causes, see Table 29 to 5. If appropriate, set the device for the desired number of minutes between blood pressure determinations. When the device has determined the blood pressure reading, note the digital results. 10. Remove the cuff from the client's arm. Safety alert. Electronic/automatic blood pressure cuffs can be left in place for many hours. Remove the cuff and check skin condition periodically. The client uses it for the length of stay, and then it is discarded. Rationale: this decreases the risk of spreading infection by sharing cuffs. 12. Document and report pertinent assessment data according to agency policy. Record two pressures in the Form 130/80 where 130 is the systolic, phase 1, and 80 is the diastolic, phase 5, pressure. Record three pressures in the Form 130/90/0, where 130 is the systolic, 90 is the first diastolic, phase 4, and sounds are audible even after the cuff is completely deflated. Use the abbreviations RA or RL for right arm or right leg, and LA or LL for left arm or left leg. 11. Wipe the cuff with an approved disinfectant. Rationale: cuffs can become significantly contaminated. Many institutions use disposable blood pressure cuffs. Report any significant change in the client's blood pressure. Also report these findings: systolic blood pressure of an adult above 140 mmHg, diastolic blood pressure of an adult above 90 mmHg, systolic blood pressure of an adult below 100 mmHg. Lifespan considerations: blood pressure. Infants use a pediatric stethoscope with a small diaphragm. The lower edge of the blood pressure cuff can be closer to the antecubital space of an infant. Use the palpation method if auscultation with a stethoscope or DUS is unsuccessful. Arm and thigh pressures are equivalent in children under 1 year of age. The systolic blood pressure of a newborn averages about 75 mmHg, D'Amico and Barbarito, 2012. Children blood pressure should be measured in all children over 3 years of age, and in children less than 3 years of age with certain medical conditions, example, congenital heart disease, renal malformation, medications that affect blood pressure. Explain each step of the process and what it will feel like. Demonstrate on a doll. Use the palpation technique for children under 3 years old. Cuff bladder width should be 40%, and length should be 80% to 100% of the arm circumference, figure 29 to 24. Take the blood pressure prior to other uncomfortable procedures so that the blood pressure is not artificially elevated by the discomfort. In children, the diastolic pressure is considered to be the onset of phase 4, where the sounds become muffled. In children, the thigh pressure is about 10 mmHg higher than the arm pressure. One quick way to determine the normal systolic blood pressure of a child is to use the following formula. Normal systolic BP 581, 2-3 child's age in years. Older adult's skin may be very fragile. Do not allow cuff pressure to remain high any longer than necessary. Determine if the client is taking antihypertensives and, if so, when the last dose was taken. Medications that cause vasodilation, antihypertensive medications, and also the loss of baroreceptor efficiency in older clients place them at increased risk for having orthostatic hypotension. Measuring blood pressure while the client is in the lying, sitting, and standing positions, and noting any changes, can determine this. If the client has arm contractures, assess the blood pressure by palpation, with the arm in a relaxed position. If this is not possible, take a thigh blood pressure. Figure 29 to 24 pediatric blood pressure cuffs. Safety. M29B_Berm 4362_10_SE_CH29.IND 506 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 507. Number 153613 CUST, Pearson O. Berman PG Number 507 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. Oxygen saturation. A pulse oximeter is a non-invasive device that estimates a client's arterial blood oxygen saturation, SAW2, by means of a sensor attached to the client's finger, figure 29 to 25, toe, nose, earlobe, or forehead, or around the hand or foot of a neonate. The oxygen saturation value is the percent of all hemoglobin binding sites that are occupied by oxygen. The pulse oximeter can detect hypoxemia, low oxygen saturation, before clinical signs and symptoms, such as a dusky color to skin and nail beds, develop. The pulse oximeter's sensor has two parts, two light-emitting diodes, LEDs, one red, the other infrared, that transmit light through nails, tissue, venous blood, and arterial blood, and B, a photodetector placed directly opposite the LEDs, example, the other side of the finger, toe, or nose. Because the photodetector measures the amount of red and infrared light absorbed by oxygenated and oxygenated hemoglobin in peripheral arterial blood, it is reported as SpO2. Normal oxygen saturation is 95% to 100%, and below 70% is life-threatening. Pulse oximeters with various types of sensors are available from several manufacturers. The oximeter unit consists of an inlet connection for the sensor cable, and a faceplate that indicates A, the oxygen saturation measurement, and B, the pulse rate. Cordless units are also available, figure 29 to 26. A preset alarm system signals high-end. Figure 29 to 25 fingertip oximeter sensor, adult. Figure 29 to 26 fingertip oximeter sensor, cordless. Amelie Benoist /BSIP/Alami. low SpO2 measurements and a high and low pulse rate. The high and low SpO2 levels are generally preset at 100% and 85%, respectively, for adults. The high and low pulse rate alarms are usually preset at 140 and 50 beats/min for adults. These alarm limits can, however, be changed using the manufacturer's directions. Factors affecting oxygen. Saturation readings. Among the factors influencing oxygen saturation readings are hemoglobin levels, circulation, activity, and exposure to carbon monoxide. Hemoglobin. If the hemoglobin is fully saturated with oxygen, the SpO2 will appear normal even if the total hemoglobin level is low. Thus, the client could be severely anemic and have inadequate oxygen to supply the tissues, but the pulse oximeter would return a normal value. Circulation. The oximeter will not return an accurate reading if the area under the sensor has impaired circulation. Activity. Shivering or excessive movement of the sensor site may interfere with accurate readings. Carbon monoxide poisoning. Pulse oximeters cannot discriminate between hemoglobin saturated with carbon monoxide versus oxygen. In this case, other measures of oxygenation are needed. Skill 29-7 outlines the steps in measuring oxygen saturation. Home care considerations. Blood pressure. If the client takes blood pressure readings at home, the nurse should use the same equipment or calibrate it against a system known to be accurate. Observe the client or family member taking the blood pressure and provide feedback if further instruction is needed. Home blood pressure measurement done by the client or family can confirm pressures identified when the client is seen in a clinic or office setting. This may be significant because so-called white coat hypertension can occur, which is an elevation in blood pressure due to mild anxiety associated with the healthcare provider's presence, who historically wore a white laboratory coat. An elevated blood pressure may be dismissed as the white coat phenomenon when, in fact, the blood pressure is truly elevated. If the client is in a chair or low bed, position yourself so that you maintain the client's arm at heart level, and you can read the sphygmomanometer at eye level. Patient-centered care. M29B_Berm 4360-10_SE_CH29.IND 507 February 12, 14, 5:51 p.m. 508 Unit 7 Assessing Health. Number 153613 CUST, Pearson O, Berman PG Number 508 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Purposes to estimate the arterial blood oxygen saturation, to detect the presence of hypoxemia before visible signs develop. Assessment. Assess the best location for a pulse oximeter sensor based on the client's age and physical condition. Unless contraindicated, the finger is usually selected for adults. The client's overall condition including risk factors for development of hypoxemia, example, respiratory or cardiac disease, and hemoglobin level. Vital signs, skin color and temperature, nail bed color, and tissue perfusion of extremities as baseline data. Adhesive allergy. Planning. Many hospitals and clinics have pulse oximeters readily available for use with other vital signs equipment, or even as an integrated part of the electronic blood pressure device. Other facilities may have a limited supply of oximeters, and the nurse may need to request it from the central supply department. Delegation. Application of the pulse oximeter sensor and recording of the SpO2 value may be delegated to UAP. The interpretation of the oxygen saturation value and determination of appropriate responses are done by the nurse. Interprofessional practice. Measuring oxygen saturation may be within the scope of practice for many healthcare providers. For example, in addition to nurses, respiratory therapists may check the client's oxygen saturation before, during, and after treatment. Although these therapists may verbally communicate their findings and plan to the healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Implementation preparation: check that the oximeter equipment is functioning normally. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Choose a sensor appropriate for the client's weight, size, and desired location. Because weight limits of sensors overlap, a pediatric sensor could be used for a small adult. If the client is allergic to adhesive, use a clip or sensor without adhesive. If using an extremity, apply the sensor only if the proximal pulse and capillary refill at the point closest to the site are present. If the client has low tissue perfusion due to peripheral vascular disease or therapy using vasoconstrictive medications, use a nasal sensor or a reflectance sensor on the forehead. Avoid using lower extremities that have a compromised circulation and extremities that are used for infusions or other invasive monitoring. 5. Prepare the site. Clean the site with an alcohol wipe before applying the sensor. It may be necessary to remove a female client's dark nail polish. Rationale: nail polish may interfere with accurate measurements, although the data about this are inconsistent. Alternatively, position the sensor on the side of the finger rather than perpendicular to the nail bed. Equipment: nail polish remover as needed, alcohol wipe sheet, or towel, pulse oximeter. The aim of this study by Corin, Yount, and Khorshid, 2011, was to compare the pulse oximetry values obtained from a finger on restrained or unrestrained sides of the body. In clinical settings such as intensive care, physical restraints may be indicated to lessen the chances that clients will displace tubes and monitors. However, the most important complication in using physical restraints is impaired circulation. Thus, oxygen saturation from body parts in which circulation is impaired can be inaccurate. The research sample consists of 30 hospitalized clients. A significant difference was found between the oxygen saturation values obtained from a finger of an arm that had been physically restrained and a finger of an arm that had not been physically restrained. The mean oxygen saturation value measured from a finger of an arm that had been physically restrained was found to be 93.40, and the mean oxygen saturation value measured from a finger of an arm that had not been physically restrained was found to be 95.53. Implications: the results of this study indicate that nurses should use a finger of an arm that is not physically restrained when evaluating oxygen saturation values. The use of physical restraints is carefully evaluated because there are many possible adverse effects of their use. This study provides one additional physiological consideration, that assessment data gathered from a restrained limb may not be accurate. Evidence-based practice: are pulse oximeter readings accurate if measured on a restrained arm? Evidence-based practice. Measuring oxygen saturation. Skill 29-7. M29B_Berm 4362_10_SE_CH29.IND 508 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 509. Number 153613 CUST, Pearson O. Berman PG Number 509 Title, Cozier and Herb's Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. Measuring Oxygen Saturation, Continued. Skill 29-7. 6. Apply the sensor and connect it to the pulse oximeter. Make sure the LED and photodetector are accurately aligned, that is, opposite each other on either side of the finger, toe, nose, or earlobe. Many sensors have markings to facilitate correct alignment of the LEDs and photodetector. Attach the sensor cable to the connection outlet on the oximeter. Turn on the machine according to the manufacturer's directions. Appropriate connection will be confirmed by an audible beep indicating each arterial pulsation. Some devices have a wheel that can be turned clockwise to increase the pulse volume and counterclockwise to decrease it. Ensure that the bar of light or waveform on the face of the oximeter fluctuates with each pulsation. 7. Set and turn on the alarm when using continuous monitoring. Check the preset alarm limits for high and low oxygen saturation and high and low pulse rates. Change these alarm limits according to the manufacturer's directions. As indicated, ensure that the audio and visual alarms are on before you leave the client. A tone will be heard and a number will blink on the faceplate. 8. Ensure client safety. Inspect and/or move or change the location of an adhesive toe or finger sensor every 4 hours and a spring tension sensor every 2 hours. Inspect the sensor site tissues for irritation from adhesive sensors. 9. Ensure the accuracy of measurement. Minimize motion artifacts by using an adhesive sensor, or immobilize the client's monitoring site. Rationale: movement of the client's finger or toe may be misinterpreted by the oximeter as arterial pulsations. If indicated, cover the sensor with a sheet or towel to block large amounts of light from external sources, example, sunlight, procedure lamps, or bilirubin lights in the nursery. Rationale: bright room light may be sensed by the photodetector and alter the SpO2 value. Compare the pulse rate indicated by the oximeter to the radial pulse periodically. Rationale: a large discrepancy between the two values may indicate oximeter malfunction. 10. Document the oxygen saturation on the appropriate record at designated intervals. Evaluation: compare the oxygen saturation to the client's previous oxygen saturation level. Relate to pulse rate and other vital signs. Conduct appropriate follow-up such as notifying the primary care provider, adjusting oxygen therapy, or providing breathing treatments. Lifespan considerations: pulse oximetry. Infants: if an appropriate sized finger or toe sensor is not available, consider using an earlobe or forehead sensor. The high and low SpO2 levels are generally preset at 95% and 80%, respectively, for neonates. The high and low pulse rate alarms are usually preset at 200 and 100, respectively, for neonates. The oximeter may need to be taped, wrapped with an elastic bandage, or covered by a stocking to keep it in place. Children: instruct the child that the sensor does not hurt. Disconnect the probe whenever possible to allow for movement. Older adults: use of vasoconstrictive medications, poor circulation, or thickened nails may make finger or toe sensors inaccurate. Use a forehead or earlobe sensor if indicated, figure 29 to 27. Figure 29 to 27 oximeter sensor. Bruno Boysonet / photo researchers / science source. Home care considerations: pulse oximetry. Pulse oximetry is a quick, inexpensive, non-invasive method of assessing oxygenation. Like an automatic blood pressure cuff, it also provides a pulse rate reading. Use in the ambulatory or home setting whenever indicated. If the client requires frequent or continuous home monitoring, teach the client and family how to apply and maintain the equipment. Remind them to rotate the site periodically and assess for skin trauma. Patient-centered care. M29B_Berm 4362_10_SE_CH29.IND 509 February 12, 14, 5:51 p.m. 510 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 510 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. Critical Thinking Checkpoint. 1. When you approach your older client to take her blood pressure, she tells you she doesn't want you to take it. What questions will you ask the client at this time? 2. After much exploration, the client agrees to let you take the blood pressure. After pumping up the cuff, you are unable to hear any sounds during release of the valve. What would you say to her? 3. Once you are able to measure the blood pressure, your reading is 180/110 mmHg. Before taking any action on this blood pressure, what do you need to know? 4. The pulse oximeter on the client's finger reads 85%. Her skin is warm and its color is normal. She is awake and oriented. Temperature is 37.1 degrees Celsius 98.8 degrees Fahrenheit and apical pulse is 78. What would be your next actions and why? See critical thinking possibilities on Student Resource website. Vital signs reflect changes in body function that otherwise might not be observed. Body temperature is the balance between heat produced by and heat lost from the body. Factors affecting body temperature include age, diurnal variations, exercise, hormones, stress, and environmental temperatures. For common types of fever are intermittent, remittent, relapsing, and constant. During a fever, the set point of the hypothalamic thermostat changes suddenly from the normal level to a higher than normal level, but several hours elapse before the core temperature reaches the new set point. Hypothermia involves three mechanisms: excessive heat loss, inadequate heat production by body cells, and increasing impairment of hypothalamic thermoregulation. The nurse selects the most appropriate site to measure temperature according to the client's age and condition. Pulse rate and volume reflect the stroke volume output, the COM. Pliance of the client's arteries, and the adequacy of blood flow. Normally a peripheral pulse reflects the client's heartbeat, but it may differ from the heartbeat in clients with certain cardiovascular diseases. In these instances, the nurse takes an apical pulse and compares it to the peripheral pulse. Many factors may affect a person's pulse rate: age, sex, exercise, presence of fever, certain medications, hypovolemia/dehydration, stress, in some situations, position changes, and pathology. Although the radial pulse is the site most commonly used, 8 other sites may be used in certain situations. The difference between the apical and radial pulses is called the pulse deficit. Respirations are assessed by observing respiratory rate, depth, rhythm, quality, and effectiveness. Blood pressure reflects the pumping action of the heart, peripheral vascular resistance, blood volume, and blood viscosity. Among the factors influencing blood pressure are age, exercise, stress, race, sex, medications, obesity, diurnal variations, medical conditions, and temperature. Orthostatic hypotension occurs when the blood pressure falls as the client assumes an upright position. A blood pressure cuff that is too narrow or too wide will give false readings. During blood pressure measurement, the artery must be held at heart level. A pulse oximeter measures the percent of hemoglobin saturated with oxygen. A normal result is 95% to 100%. Pulse oximeter sensors may be placed on the finger, toes, nose, earlobe, forehead, or around the hand or foot of the neonate. Chapter highlights. Chapter 29 Review. M29B_Berm 4362_10_SE_CH29.IND 510 February 12, 14, 5:52 p.m. Chapter 29 Vital Signs 511. Number 153613 CUST, Pearson, Berman PG Number 511 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 1. The client's temperature at 8 a.m. using an oral electronic thermometer is 36.1 degrees Celsius 97.2 degrees Fahrenheit. If the respiration, pulse, and blood pressure were within normal range, what would the nurse do next? 1. Wait 15 minutes and retake it. 2. Check what the client's temperature was the last time it was taken. 3. Retake it using a different thermometer. 4. Chart the temperature, it is normal. 2. Which client meets the criteria for selection of the apical site for assessment of the pulse rather than a radial pulse? 1. A client who is in shock. 2. A client whose pulse changes with body position changes. 3. A client with an arrhythmia. 4. A client who had surgery less than 24 hours ago. 3. When the nurse enters a client's room to measure routine vital signs, the client is on the phone. What technique should the nurse use to determine the respiratory rate? 1. Count the respirations during conversational pauses. 2. Ask the client to end the phone call now and resume it at a later time. 3. Wait at the client's bedside until the phone call is completed, and then count respirations. 4. Since there is no evidence of distress or urgency, postpone the measurement until later. 4. For a client with a previous blood pressure of 138/74 mmHg and pulse of 64 beats/min, approximately how long should the nurse take to release the blood pressure cuff in order to obtain an accurate reading? 1. 10 to 20 seconds. 2. 30 to 45 seconds. 3. 1 to 1.5 minutes. 4. 3 to 3.5 minutes. 5. It would be appropriate to delegate the taking of vital signs of which client to unlicensed assistive personnel? 1. A client being prepared for elective facial surgery, with a history of stable hypertension. 2. A client receiving a blood transfusion, with a history of transfusion reactions. 3. A client recently started on a new antiarrhythmic agent. 4. A client who is admitted frequently with asthma attacks. 6. An 85-year-old client has had a stroke resulting in right-sided facial drooping, difficulty swallowing, and the inability to move self or maintain position unaided. The nurse determines that which sites are most appropriate for taking the temperature. Select all that apply. 1. Oral. 2. Rectal. 3. Axillary. 4. Tympanic. 5. Temporal artery. 7. A nursing diagnosis of ineffective peripheral tissue perfusion would be validated by which one of the following? 1. Bounding radial pulse. 2. Irregular apical pulse. 3. Carotid pulse stronger on the left side than the right. 4. Absent posterior tibial and pedal pulses. 8. The nurse reports that the client has dyspnea when ambulating. The nurse is most likely to have assessed which of the following? 1. Shallow respirations. 2. Wheezing. 3. Shortness of breath. 4. Coughing up blood. 9. When auscultating the blood pressure, the nurse hears, from 200 to 180 mmHg, silence, then, a thumping sound continuing down to 150 mmHg, muffled sounds continuing down to 130 mmHg, soft thumping sounds continuing down to 105 mmHg, muffled sounds continuing down to 95 mmHg, then silence. The nurse records the blood pressure as underscore 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 10 in figure 29 to 28, which number indicates the client's oxygen saturation as measured by pulse oximetry. Underscore 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 underscore. See answers to test your knowledge in Appendix A. Test your knowledge. Figure 29 to 28 Vital Signs Monitor. M29B underscore berm 4362 underscore 10 underscore SE underscore CH29 .IND 511 February 12, 14, 5:52 p.m. 512 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 512. Title, Cozier and Herb's Fundamentals of Nursing 10E. C/M/Y/K. Short/normal. Design Services of S4 Carlisle. Publishing Services. Suggested Reading Draws, P. Abdallah, M., and Rahman, M. 2012. Blood Pressure Measurement, Clinic, Home, Ambulatory, and Beyond. American Journal of Kidney Diseases, 60, 449 to 462. Joy, 10.1053/J.Adjct.2012.01.026 Technologic advances have led to improvements in measuring blood pressure in medical offices and other settings. This review outlines various methods for evaluating blood pressure and the clinical utility of each type of measurement. For example, measuring blood pressures at home may lead to more active client participation in healthcare and has the potential to improve blood pressure control. Ambulatory blood pressure monitoring enables measuring nighttime blood pressures and diurnal changes, which may be the most accurate predictors of risk associated with elevated blood pressure. Related research Buttra, P. and Goyle, S. 2013. Comparison of rectal, axillary, tympanic, and temporal artery thermometry in the pediatric emergency room. Pediatric emergency care, 29, 1, 63-66. doi, 10.1097/PEC.0B013E31827B5427 Koshtal, Carney, S., and Gillies, A. 2010. The impact of arm position and pulse pressure on the validation of a wrist cuff blood pressure measurement device in a high-risk population. International Journal of General Medicine, 3, 119-125. References Cavelli, M., Wood, C., and Urandi, H., 2012. Biologic measures as epidemiological indicators of risk for the development of hypertension in an African American adolescent population. Journal of Cardiovascular Nursing, 27, 476-484. doi, 10.1097/JCN.0B013E31822F7971 D'Amico, D., and Barbarito, C., 2012. Health and Physical Assessment in Nursing, 2nd ed. Upper Saddle River, New Jersey, Pearson. Fonseca Reyes, S., Forsyth McQuarrie, A., and Garcia de Alba Garcia, J. E. 2012. Simultaneous blood pressure measurement in both arms in hypertensive and non-hypertensive adult patients. Blood pressure monitoring, 17, 4, 149-154. doi, 10.1097/MBP.0B013E328356881E2 James, P.A., Opral, S. Carter, B.L., Cushman, W.C. Dennison Himmelfarb, C. Handler, J. Ortiz, E. 2014. 2014 Evidence-Based Guideline for the Management of High Blood Pressure in Adults. Report from the panel MEM Bears appointed to the 8th Joint National Committee, JNC 8. Journal of the American Medical Association, 311, 507-520. doi, 10.1001/JAMA.2013.284427 Corin, E.A., Yant, G.H., and Khorshid, L., 2011. Comparison of oxygen saturation values obtained from fingers on physically restrained or unrestrained sides of the body. Clinical Nurse Specialist, 25, 2, 71-74. doi, 10.1097/NUR.0B013E31820 EF2 Major, DR, 2012. Orthostatic hypotension, pathophysiology, problems, and prevention. Home Healthcare Nurse, 30, 525-530. doi, 10.1097/NHH.0B013E31826-6805 Marigold, J., Arias, M. Vasallo, M. Allen, S. and Kwan, J. 2011. Autonomic dysfunction in older people. Reviews in Clinical Gerontology, 21, 1, 28-44. doi, 10.1017/S0959259810000286 McFarlane, J. 2012. Ask the Experts, Blood Pressure Measurement in Obese Patients. Critical Care Nurse, 32, 6. 70-73. doi, 10.4037/CCN20124889. Muniz, J. Sethi, R. K. Zaghi, J. Zinial, S. I. and Sandora, T. J. 2012, Predictors of Stethoscope Disinfection among Pediatric Healthcare Providers. American Journal of Infection Control, 40, 922-925. doi, 10.1016/j.agic.2011.11.021 National Institutes of Health, National Heart, Lung, and Blood Institute. 2004, the seventh report of the Joint National Committee for the Detection, Evaluation, and Treatment of High Blood Pressure, complete report. Retrieved from http://www.nhlby.nih.gov/guidelines/hypertension JNC7 full.htm Penning, C. van der Linden, J.H., Tibble, D., and Evenhuis, H. 2011. Is the temporal artery thermometer a reliable instrument for detecting fever in children? Journal of Clinical Nas ING, 20, 1632-1639. doi, 10.1111/j.1365-2702.2010.03568.xpnar, R, Italkin, S, and Watson, R, 2010. The effect of crossing legs on blood pressure in hypertensive patients. Journal of Clinical Nursing, 19, 1284-1288. doi, 10.1111/j.1365-2702.2009.03148.x. Rubia, J. Arias, A. Sierra, A. and Aguirre Jamie, A. 2011, Measurement of Body Temperature in Adult Patients, Comparative Study of Accuracy, Reliability, and Validity of Different Devices. International Journal of Nursing Stud IES, 48, 872-880. doi, 10.1016/j.agenurse.2010.11.003. Selected Bibliography Akbalat, T. Idodu, T. Erdem, E. and Karatas, A. 2011. Inaccuracy of home sphygmomanometers, A Perspective from Clinical Practice. Blood Pressure Monitoring, 16, 168-171. doi, 10.1097/mbp.0b013e3283448 CA52 L.B. Evans, C. W. Ingram, L.L. Tisdale, P.P. Watson, S.P. and Jan Ken, J.K., 2011. Agreement between temporal artery, oral, and axillary temperature measurements in the perioperative period. Journal of Perianesthesia Nursing, 26, 3, 143-150. doi, 10.1016/j.jopin.2011.03.010 Cacciolotti, C. Hainan, O. Dufelt, C. Alperovich, A. and Surio, C. 2013. Categories of hypertension in the elderly.